Thank you, ma'am. Now I would like to request Co-Chairperson Dr. Pratibha Dawani ma'am to welcome CEO Sir Dr. Anuj Maharaj sir with a full bouquet and compliment.
Thank you, ma'am. I would like to request Secretary Sir Dr. Mahavir Mundra sir to welcome Vice Dean Sir Dr. B.R. Singh sir to the floor bouquet and a memento.
Now I would like to request Dean ma'am Dr. Rajat Pratibha ma'am to felicitate Dr. Manju Chandrasekhar ma'am with the floor bouquet and a memento.
Thank you, ma'am. Now I would like to request CEO Sir Dr. Anuj Maharaj sir to felicitate Dr. Pratibha Dawani ma'am with a floor bouquet and a memento.
Thank you, sir. I would like to request Vice Dean Sir Dr. B.R. Singh sir to felicitate Dr. Mahavir Mundra sir with a floor bouquet and a memento.
It's an exchange of garland.
Thank you, sir. I would like to request CMS Sir Dr. B.R. Singh sir to felicitate Dr. Neha Bhatt ma'am with a floor bouquet and a memento.
Now I request Dr. Manju Chandrasekhar ma'am to deliver the welcome address. A very good morning to all the distinguished guests on the dais, respected speakers, respected chairpersons, senior delegates, and my dear colleagues. I, Dr. Manju Chandrasekhar, organizing chairperson of today's CME, feel privileged to welcome you all to National CME on Advancement in Laboratory. Laboratory diagnostics is one of the main assistants to the doctor in making the diagnosis and choosing the treatment method, and has a good as other examination methods in terms of information capacity. As all of us are very much aware of technically and digitally advanced today's healthcare system, I think lab medicine is that. With a great leap in the biotechnology, lab medicine has drastically changed, and it's a need of the hour that all of us are aware of. The use of new technologies allow us to obtain more accurate data. Therefore, laboratory equipment must be constantly modernized, and laboratory diagnostic specialists must gain knowledge and obtain modern equipment skills. Along with the new technologies, in today's session, we are also parameters of efficacy of lab, pre-analytical arrangement, as well as importance of the quality control in that medicine on day-to-day basis. So let's have a glimpse of all these advancements and update ourselves about the new version of the working of the lab medicine. All these sessions will be delivered by our student speakers. I hope all of you will enjoy this activity. Thank you so much. Once again, I welcome you.
Thank you, ma'am. I would like to request now CEO Sir Dr. Anup Mehra sir to kindly address the gathering.
On the dais, of the dais, and my dear friends. It's a pleasure to be here. Every week we are having some kind of CMO or other from various departments related to advancement in laboratory science, what madam has mentioned. As a physician and seeing the last 2 decades, I'm not sure whether too much dependency on the diagnostics and diluting the clinical skills. That has mattered. The students today are not touching their patients. Many of the youngsters, many of the clinicians whom I am seeing, the patient are not being touched, and that affects a lot. And they give the rounds also in our hospital, and it's everywhere, wherein the old concept of having a clinical equipment and then asking for a diagnostic confirmation. The question of provisional diagnosis or a differential diagnosis that has diluted in the recent past, but I'm sure that a compromise can be reached, because when we talk about evidence-based medicine, this is also essential. But then while India has to be ensured, where the clinicians and the lab medicine divisions, they do more at part. And in the recent past, well, I've seen that various multinational companies, they are entering this foray. I'm not sure whether it is good or bad, but let's see. Thank you. Thanks a lot.
Thank you, sir. I would like to request Dean Ram, Dr. Ujjwal Ram, to please say a few words.
एक कमल ऑप्टिकल का ये बुलाएगा पास ये 30 पॉइंट क्या है
on behalf of Datta Institute of Higher Education and Research and Datta Medical College, Nagpur, I welcome you all, respected dignitaries on the dais, Dr. Anup Mehra sir, CEO of Mege Group of Institution, Directors, Shalini Tai Mege Hospital and Research Center, Dr. V.R. Singh, Vice Dean of Datta Medical College, Chairpersons, Chairman of the CME, Dr. Manju Chandan Phide, Co-Chairman, Dr. Pratibha Davande Madam, Organizing Committee, all the faculty members sitting over here, and my dear students. Happy to see this type of gathering who are sitting here offline. I also welcome all the delegates who have joined online. Just now, as I said, the title of our university has changed recently into Datta Mege Institute of Higher Education and Research. Recently, it was called as Datta Mege Institute of Medical Sciences. So, by the title itself, you can judge the growth of the university. So, because of admissions, not only the courses which we have, it is not only the medical courses, but other courses are also incorporated in the university. Other growth as well. Because of that, we are with the title Datta Mege Institute of Higher Education and Research. Now, this Datta Mege Medical College is a off-campus college of our university. We are still in a toddler stage. We are 3 years old, and we are going to have third batch right now. The admissions are going on. But I am very happy to see that the growth of this college, the way we are accelerating, so that is very good. Our sister college in Varda is 33 years old, In university, we had in the year 2005. We are here 3 years old, but we are almost parallel to our sister college, that is Jawaharlal Medical College. And this is all because of all hard efforts taken by my team, that is my faculty members. One of the example is that recently only pathology had their CME on blood transfusion, but they had joined Department of Biochemistry, I think in a span of 1 month only. They have joined Department of Biochemistry. Actually, it is mandate for us to have only one CME per year annually. But now they are like organizers for this CME. So that is one of the example how hard efforts the faculties are taking, like 2 CMEs also they are organizing. And actually in our university, the faculties are not that free to organize 2 CMEs, but it's a good gesture. So I'm very happy for that, for the Department of Pathology also for rendering support to Department of Biochemistry. Then I would request the faculties that they should have a look at our hospital also, the EMD building, super specialty building, and the whole college as well. But the Central Museum is also very nice. We are having a lot of appreciation from number of WhatsApp groups and other platforms. So when you are here, please have a look those library and Central Museum also. The topic which has been chosen for this CME, I think it is a need-based topic. In many of our hospital meetings, we found that this type of topic, what is pre-analytical preparation and aspects, those all things needs to be discussed. Accordingly, Dr. Chandan Khede has chosen the topic. On behalf of organizing, on behalf of CEO hospitals, on behalf of Vice Dean, I would like to assure whole gathering that this CME will be coming up with a good outcome, with good academic deliberations by our eminent speakers. I wish good luck to the organizing team. Thank you so much.
Thank you, ma'am. Before we begin the proceedings of scientific session, I would like to invite Dr. Mahavir Mundra, sir, Associate Professor Biochemistry, to propose the final word.
On behalf of the organizing committee of Department of Biochemistry and Pathology, Dr. Medical College, I feel honored to propose the formal vote of thanks. First and foremost, I express my gratitude toward the Honorable Chancellor Sir, Sri Dattaji Sahib, for their vision that we are here. Honorable Sri Sagar Mehta Sir carried forward Dattaji vision leading to the inception of this very institute. We are grateful to you, sir. Honorable Pro Chancellor Sir, Dr. Ved Prakash Mishra, with his intellectual and futuristic concept, brought in our university to its current eminent state of glory. We are deeply indebted to you, sir. With their hard work and excellent administrative skills, Honorable Vice Chancellor Sir, Dr. Lalit Barbare and predecessors, Honorable VC, Dr. Rajiv Bodle Sir, built and nurtured the institute. Our heartfelt gratitude to you, sir. Honorable Pro DC Sir, Dr. Gaurav Mishra, with his freshness and modernity of the ideas, assures a promising future ahead. We are obliged to have such a young and dynamic administrator. Honorable Dean Ma'am, Honorable Dr. Anup Marar Sir, Honorable B.R. Singh Sir, and Dr. Vasant Gawande Sir, with their superlative administrative skills, ensures smooth running of this off-campus institute. We are very thankful to you, sir and madam. We are thankful to our speakers for taking out their precious time to impart their valuable knowledge to us. We acknowledge and appreciate your efforts. I express respect and gratitude for our highly learned and vastly experienced chairpersons for taking out time from their busy schedule and joining us to share their experience. We are grateful to our delegates for showing keen interest in this topic and joining us. I also thank and appreciate our students of MBBS and Allied Sciences. Hope this CME gives you an insight on the basics and advancement in the laboratory science. Thank you.
Thank you, sir. With this, let us move forward to our scientific session of CA.
She has vast experience of private practice around 27 years and teaching experience around 20 years. She has worked in different chemistry. She is a guide for MD and PhD, and she has been competitions in national and international events. I request Dr. Dhawan to start with this section.
that your instruments are doing good or not. And where you have to improve or whether you are okay with it. So equality was way to protect. So what is the need of turnaround time? In spite of requirement for any or any DH wants a proper or perfect turnaround time to call your laboratory efficient. Next. Next. If there is a remote, I will have with me. So what is the need of that? Why the accreditation people needed to fix the that? It is to guarantee the diagnostic services. It is to guarantee a diagnostic services laboratory must deliver accurate, dependable, and prompt test results. Now let me tell you, when it comes to the laboratory consultants, the laboratory consultants are always more aware of dependable and accurate quality kind of report. And when it comes to the consultants, consultants, obviously they want dependable and accurate, but they are more concerned with the timely reports. That they need a timely reports. A timely reports gets into the tag. You have to maintain a tag to keep the patient and the clinician satisfied. Tag is a quality indicator to evaluate the effectiveness, efficacy, and the testing process and the satisfaction of the clinicians and the patients. If you give it on the time, then only you will be able to know.
will be highlighting the same. I would like to mention here important who also is very much critical how sample is collected and transferred because the organisms flow, the contaminant flow is not in our hand. It's वार्ड में पड़ा है वो 4-5 घंटे के बाद आ रहा है फिर इसमें कंटामिनेशन फिजिशियंस माइक्रोबायोलॉजिस्ट इसको गालियां देते हैं हम तो कुछ अलग सोच रहे थे ये कुछ अलग देते हैं बट इट वाज नेवर सीन कि वो यूरिन सैंपल वार्ड में कितना टाइम पड़ा है सैंपल गया या नहीं एंड इवन टुडे आल्सो वी आर फेसिंग फॉर HIV आल्सो इट इज मैंडेटरी टू हैव अ कंसेंट फॉर्म विद दिस बट रोज टेक्नीशियंस के मुझे फोन आते हैं कि मैडम ये वार्ड से नहीं आया ये पेशेंट का नहीं आया कंसेंट फॉर्म नहीं आया विदाउट कंसेंट फॉर्म वी कैन नॉट पुट द टेस्ट दैट इज द गाइडलाइन और अभी भी मेरे पास 2 मैसेजेस आए हैं यहाँ दोनों भी HOD बैठे हैं मैं बात करूंगी कि पेशेंट के कंसेंट फॉर्म ही नहीं आते थे सो हाउ कुड वी proceed further without consent form because national team is also there they are doing its vigilance team they आके वो चेक करते हैं हमारे रजिस्टर्स कंसेंट फॉर्म अगर पेशेंट के कंसेंट नहीं है पूरा हम पे आता है एंड आई विल मींस रिक्वायर्ड वन सर्कुलर रिगार्डिंग दैट कि रोज मुझे ये आ रहा है कि कंसेंट फॉर्म नहीं आ रहे हैं चेक कर रहे हैं पेशेंट का एंड पेशेंट्स आप लोगों के पास रहते हैं ना कि हमारे पास so we will not do that with samples without a consent form
So in short, we all laboratory medicine people will request all the clinicians to reduce the pre-analytical
Yes.
delay, and then we assure you to reduce the analytical.
nice knowledge madam thank you any questions
Everyone sir, teachers sir, you can ask. Otherwise, we discuss the
yes इस साइड भी रहते हैं इस साइड भी रहते हैं
Clinicians part I can understand the patients are you are facing the patients and then the patients are shouting at you अभी तक के रिपोर्ट कैसा नहीं आया and then you become mad कि अभी तक के रिपोर्ट कैसा नहीं आया then you call me then I become mad अभी तक के कब आया तुम्हारा this sort of
Yes.
things are undesirable and I think we should do as a team to solve the problem.
yes. thank you
Thank you, Dr. Pratika Dhanapal, for imparting your precious knowledge with us. Thank you, Dr. Suvarna Sandekar and Dr. Trupti Verma for chairing the session.
I would like to invite Dr. Suvarna Sandekar to felicitate our speaker, Dr. Pratibha Davande, memento as token of love and appreciation. I would like to
फोकस होना क्या
हो गया सर हो गया उसको
now I request Dr. Chandu Chandan to felicitate our chairperson, Dr. Suvarna Sandekar and Dr. Trupti Verma.
संडे में को पेट रखी है मैडम को क्या लपड़ा नहीं होने के बाद में ठीक
For the second session, which will be focusing on pre-analytical clearance by Dr. Abhijit Nimor sir. Dr. Abhijit sir will be joining us online. And please to invite Dr. Ajay Khade sir and Dr. Sanskrit to chair the session. Dr. Anaga Sahasrabudhe is a professor in Department of Physiology, Datta Mehta Medical College, Nagpur, and has a vast teaching experience of 15 years, and has many national and international publications. Over to you, sir.
So, good morning, all of you. Myself, Dr. Rajiv. Actually, I'm Professor Department of Pharmacology. They are both are chairperson for the section on the analytical error. And the speaker is Dr. Abhijit. Sir is presently working as associate professor at GMC Satara. He is alumni of GMC 2001 batch, GMC Nagpur. He has done his PhD from Simanga. He has experience as assistant professor from St. G.S. Medical College in Cape Hospital, Mumbai. Thereafter, he worked as assistant professor at GMC Nagpur. After that, associate professor at GMC Satara. Sir has also authored a book titled Case-Oriented Approach in Biochemistry. He is internal auditor at NABL. To his credit, there are 20 international and national publications. So, with this biodata, I welcome Dr. Abhijit Nimur. Yeah. Yes.
Hello, am I audible and visible? Shall I start?
Yes, sir.
Good morning, everyone. Hello. 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 Audible, sir?
Yes, sir.
Good morning, all participants in this hearing. I am Dr. Abhijit Ninghod, presently working as Associate Professor, GMC Satara. First, I would like to thank all the organizing committee members for allowing me to speak as a guest lecturer in CME. And today's topic presentation is or we also call it as a pre-analytical errors. So we'll discuss today some commonly encountered pre-analytical error in today's lecture. So what are the risks of errors? What we are going to do with this error if it occurs in our laboratory, what will be its consequence? So if any error occurs, there will be inadequate Hello. So there will be improper patient treatment. There will be diagnosis. Unmute here. Hello. So here we are discussing the consequences of error because of error, there will be misdiagnosis or there will be delayed diagnosis. And because of this misdiagnosis or delayed diagnosis, there will be detrimental effects on patient's health. And the patient may cause because of the laboratory error. Then there will be there will be inappropriate public health action. Depending on your lab test, there will be different action, inappropriate action, and it will lead to undetected communicable disease outbreaks. And certainly, if we are wasting our money or resources in wrong diagnosis, so it will be a waste of our resources, monetary as well. So we should avoid the error wherever it occurs in laboratory. This is the test. It starts from a patient, then there will be a test selection by a physician, then there will be collection by phlebotomist, and then sample transport to the laboratory. In laboratory, we perform the analysis on various high-end machines in our lab. Then after this examination phase, we have post-analytical phase, that is report creation, report transport to the patients. So from the doctor's prescription to the when we analyze the sample on the machine, that period we call it as a pre-examination phase. Then the analytical phase, when we perform the test on the machine, and post-analytical means reporting phase. So today we are going to discuss the errors which may occur during the pre-analytical phase. So these are the common errors, combined errors, common errors. There will be no equipment properly maintained. Then many times individual his or her responsibility clearly, no written procedure, no SOPs. Written procedures are there, SOPs are there, but nobody is following it. There are not trainings or competent persons are not performing those tests. Then there will be some transcription error and texts are not done. Then text kits not properly stored. Then you see external requests are not performed properly. So all these are combined errors. Pre-analytical, we why we are discussing today, why we are doing important pre-analytical phase, because many studies are showing that about 60 to 70% errors are occurring in the pre-analytical phase. And mostly this pre-analytical phase is occurring in the outside of the laboratory. Since some phlebotomists are sitting their area, and we are getting samples from ward. So mostly these errors are occurring outside ward. Hello. 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 Most of the errors are occurring in analytical phase. That's why we are concentrating here today on errors occurring in the pre-analytical phase. And you will say, hello. You will say that we don't have control over the things which are not occurring in our laboratory. So many of the things are occurring outside our laboratory, but still, according to ISO 15189 2012, we have to deal with all these pre-analytical errors, and it is the responsibility of that particular laboratory to reduce the pre-analytical errors occurring in their testing process. These are the different phases, different of pre-analysis. Starting with sampling, there will be tube series syringe labeling, then the site of preparation where you are going to pierce the needle, then sample collection, then comes the transport phase where specimen delivery from the collection area to the laboratory, and finally before testing the sample or machine, we process the sample, like this is the sample, and then we process it, the serum on our high-end machines. Now, what are the different pre-analytical challenges? Many persons involved in this pre-analytical phase, like physicians. Many a times, physician writing it not properly identified by the phlebotomist. Then, instructing patients or staff do not clearly instruct the patient regarding regarding their preparation. Then there are chances of phlebotomist nurses which are not able to give advice to these patients properly, and many times what happens, sample ID are not identified properly. Then there will be delay from runners to transport sample from collection area to the laboratory, and many times persons which are receiving the samples are not able to justify their job. Then this is more challenging in teaching hospital, as if we are running a small standalone lab, we are able to minimize this pre-analytical errors because less persons are involved in this pre-analytical phase. But as in case of teaching hospitals, tertiary care hospitals, it is very difficult to manage these pre-analytical challenges. And certainly we have some analytical variables, like most commonly we have lipemic sample, hemolytic sample, or icteric sample. So we'll discuss about these analytical variables in detail. First, we discuss different types of error which are occurring in the laboratory. First, starting with patient identification. These are the different types of error. Patient identification, there may be mistake in patient identification, phlebotomy technique. Then will be error in collection procedure, error in specimen transport, or specimen processing. So we one patient and label of another patient, because there is a heavy rush in our collection area. This is about the, and if it's critical and he cannot say his name, many times mistake can happen from our because they wrongly label the patient, and then patient relatives, doctors, clinician come to us, with us, not getting from times mistake from their side. So we should be in contact with our physician to minimize this kind of identification error. Mostly we So we can add a patient identification bracelet, should be barcoded. Then certain patient related complications are there. So some factors affected by diet, like you cannot compare the blood glucose levels with the postprandial blood glucose level. Then because of diet, sample may get heavy lipid diet, sample may get lipemic. Then because of exercise, if patient come immediately after exercise to your laboratory, his LDH will be raised, you will get the LDH of that patient raised. Then you might think that his blood glucose may be low after exercise, but this is not a condition. Because of the gluconeosis, after exercise, the blood glucose levels you will get increased. Then some certain cardiac markers also you may get increase after exercise. Then certain patients may have alcohol or iodine allergies. So you can use the alternative cleansing agent like chlorhexidine to clean up the area. Many times those interns or the laboratory person or the nurses keep those tubes unlabeled. So we are clueless. Whenever sample come to our laboratory, we are clueless which patient's sample is this. So we should communicate with the wards and minimize this kind of error, labeling error. Then phlebotomy errors. As you know, phlebotomy is a highly complex skill requiring expert knowledge, dexterity, and critical judgment. Many errors are occurring while the drawing blood from a patient, and it may lead to patient injury, or that person drawing the blood may get injured with the needle stick injury. Now, what happens here? We use the improper gauge to draw the blood sample. If we are using 24, 25 number needle, the sample is bound to get hemolyzed, right? And if we use the 18 gauge needle, there will be a turbulence, and therefore sample will not be properly, we won't get the proper sample. So therefore we should use the proper gauge from 20 to 23. Recommended is from 20 to 23. Only for neonates and children we can use 24 number needle. Then phlebotomy technique errors. There will be venous access difficulties, like in case of old age patient, there may be obstructed, hardened, scarred vein, and veins will be difficult to locate in case of obese patient. So we can use, in that case, we can use alternative sites. Vein collapse we can see in case of hypovolemic patients. So in that case, we can use the appropriate needle size like 24, or we can use smaller evacuated collection tubes. We should avoid taking sample where the IV line is attached, because the many times sample get diluted. Or if we are drawing the sample for blood glucose, and in the same line we have attached the D5, dextrose 5, so we will get the elevated levels of glucose. And in case of mastectomy, we should avoid the side from which mastectomy has been done. And also we should avoid the collection of sample from edematous areas. It will lead to improper test results. Then about the tourniquet application. We should not apply the tourniquet more than 1 minute, because different analytes we might get increase, like we get increased potassium level, or we get increased calcium level, ionic calcium level. Total calcium level will be the same, but ionic calcium levels we get increased if we keep the tonic weight for more than 1 minute. So we should educate our phlebotomist regarding this aspect. Then there should be proper cleansing of venipuncture site. We should wait, allow that place to dry, and then only we keeping dewelled edge up, we should pierce the site. Then we should maintain the proper order of draw. So if we are collecting the samples for different tests, we should first collect for blood culture. Then we should go for citrate coagulation profile, APTT. Then we can draw the serum sample in serum tube, then heparinized bulb, EDTA, and lastly for glucose in oxalate fluoride bulb. So this order of draw should be maintained. Then the time of collection. Most reference ranges are designed that we have drawn the sample in the morning hours, 7 to 9. Most of the reference ranges are like that only. Then for therapeutic drug monitoring, after minimum period, let us say the peak period of that drug is 6 hours, half-life is 6 hours. So in that half-life, you have to take the sample. Then this is condition, like most of the sample we are collecting in morning hours and in fasting state. So there are certain parameters which are affected by the time in which you are collecting the sample. Like we get peak level of cortisol in the morning and peak level of growth hormone at night at 10 o'clock. Many times there are preservatives added in the test collection tubes, and these preservatives are given for an amount of sample. You have to take 5 ml of sample. According to that 5 ml, the percentage of preservative is added in that tube. Instead of 5 ml, if you are collecting only 3 ml of sample, then what will happen? There will be the more amount of preservative, and that lead to wrong results. Then for capillary testing, there should not be milking of site. Milking of site, because that may lead to erroneous results. And first few drops you have to wipe it, and then next few drops you can take it for your test. You should avoid touching capillary collection tube or micro collection tube, or avoid touching the skin surface, because it may lead to contamination of puncture site and blood may get hemolyzed. Then certain specimen transport errors. Now, if we are collecting sample for ABG analysis, we should strictly immediately send that sample to the laboratory. If any kind of delay occurs, we may get the different result which are actually present in your body. So for the blood gas analyzer, blood gas analysis, this transport of sample is very important. And for certain tests, we have to maintain the cold chain. For that test, we have to we should maintain cold chain. Then only we'll get the correct results. Then the temperature. Tests like ABG and ammonia, we need the sample to be carried on the ice packs. And for the cryoglobulins, they may precipitate at low temperature. So at body temperature, we have to carry those samples to the laboratory, and immediately we should perform those tests. Then for certain parameters like bilirubin is photolabile. So there may be effect of light on bilirubin sample. So this sample should be carried in proper protected container. So here are some pre-analytical variables are given, like there are seasonal variations in concentration of vitamin D and thyroid hormone, also cholesterol, triglyceride. Then before menstruation, if we talk about menstruation, before ovulation, aldosterone levels are much more than the post-ovulatory phase. So we cannot compare the aldosterone level, one-time aldosterone level in pre-ovulatory phase, and next time performing those aldosterone level analytical phase. Then there will be a effect of smoking on different analytes like increase immediately after smoking. Immediately if the patient come to laboratory after 10 minutes or 15 minutes, you draw blood, the blood glucose levels may be raised by 10 milligram per deciliter. Also chronic alcoholics, some parameters are increased. Now the three important pre-analytical variables like hemolysis. First is hemolysis. Now in this hemolysis, we should be able to distinguish between in vivo hemolysis and in vitro hemolysis. How will you identify that this is in vivo hemolysis? After asking that patient for frequent sample, 3-4-5 बार आपने उसको ask किया है, asking, but same you are getting hemolytic sample. So there are chances of in vivo hemolysis. And in vivo hemolysis, haptoglobulin levels. If we check the haptoglobulin levels of that patient, haptoglobulin levels will be decreased, and you will get the urinary hemoglobin. Hemoglobin may be present in the hemoglobin may be present in the urine of those patients in which this in vivo hemolysis is occurring. Now, because of hemolysis, this hemoglobin comes up, and hemoglobin has a absorbance property. It can absorb the light at from 400 to 600 nanometers. It will cause the spectrophotometric interference. Then there will be a release of different components into the sample. Like LDH levels are much more in intracellular. In RBCs, LDH levels are much more. And when there is a breakdown of these RBCs, LDH come out of it, and you will get falsely elevated RBS levels in the LDH levels in the serum. Similarly, potassium levels are also intracellularly very much increased, and you will get the res levels of potassium in hemolyzed sample. Then there is a sample dilution effect, like certain parameters like glucose, albumin, creatinine. These are present in much more concentration extracellularly, and when we are mixing the intracellular component to the extracellular, there will be a sample dilution, and you will get the low levels of these parameters. Then certain chemical interferences in assays may occur, like adenylate kinase concentration is higher in RBCs, and when these RBCs are hemolyzed, this adenylate kinase comes out of the cell and it interferes with the creatinine kinase assay, and you will get the wrong results. Then second most variability, pre-analytical variable is lipemic sample. So similarly, you will get the turbid sample here, visible turbidity, because of the most common cause of this lipemia is when we collect the sample postprandially. So we can easily avoid it by taking the fasting sample. And this postprandial lipemia is because of the different types of increased raise levels of chylomicrons in the blood, chylomicrons and VLDL, because of the raised concentration of triglycerides. So this lipoproteins or lipid can cause the spectrophotometric interference, and specifically on the lower range around 300 to 400 nanometers. So for our enzyme assays, where we are using NAD to NADH conversion, NADH to NAD to NADH conversion, we are measuring. These assays are most commonly affected by lipemic sample. So there will be partitioning of sample also. When we centrifuge this lipemic sample, all the lipids were goes on the upper layer. And if you are taking the sample from upper layer, there will be different analyte concentration, and where the lipid components are present, you will get the different report. There will be interference caused by physiochemical mechanism. You will get different bands in electrophoresis and chromatography. Hello. So, should we deal with these lipemic sample? We can use the ultracentrifugation. We can centrifuge that sample at 2 lakh G. Then ultracentrifugation is not available at many places. Instead of that, we can use high-speed centrifugation, where we spin the sample at 20,000 or 10,000 G. Then there are certain lipid clearing agents which we can add to the sample. They may remove the lipids from the sample. But what happens if we are removing the lipid from sample? Many drugs are lipid soluble. Certain hormones are lipid soluble. After removing, if we are removing the lipids from that sample, those and then we are measuring those lipids, so concentration of lipid soluble drugs or concentration of lipid soluble hormones, certainly there will be decreased levels of those parameters in your sample. Lastly, the icteric sample, where the bilirubin are red. So normally the color of serum is low. It will be orange. The sample is icteric because of the raised bilirubin levels. So bilirubin can also be at 400 to 100 nanometer, and this was spectrophotometric. There are certain assays which use H2O2 as an in their like glucose, uric acid, cholesterol. These assays will more icteric sample. And to reduce the effect of this icteric sample, we can dilute sample and again and then according to, we can multiply analyze according to Lastly, the lab error management process. Everybody should be aware of the different errors occurring in the laboratory, and we should go for investigation which kind of errors are occurring. Then action should be taken on that errors, and those errors will be communicated with the physician so that we can minimize the errors in the lab. And we should routinely do this in our how going on to last slide of my presentation. How can we prevent different errors? We should educate the phlebotomists about the proper job. Then there are of laboratory persons as well as the clinician staff, phlebotomy, and we should use wherever required technology to reduce the pre-analytical errors, like we can use the barcode scanner and barcode wherever possible. So this is all from my side. Thank you very much.
Thank you, Dr. Neetu, for your excellent presentation in a very lucid manner. And before opening up the floor for discussion, I'd like to actually, what about physiological
Hello.
errors you
Hello.
had mentioned? Am I audible, sir? Dr. Neetu, am I audible?
It's not clearly, ma'am. You can ask.
Yeah, so what I was saying is physiological pre-analytical errors which you were mentioning are always there.
Yes. Like physiological errors, we cannot say physiological errors. There are physiological variations. Like age, we have age, then gender. So we have different reference ranges according to age, then different reference ranges according to the gender, wherever difference, because these are the physiological variations. Also ethnical, we should derive the reference ranges according to the different ethnic groups also certain physiological conditions, like if we are talking about pregnancy, we cannot compare the beta HCG levels of non-pregnant level with that of pregnant lady, because both beta HCG levels are different. In pregnant lady, beta HCG levels are much higher as compared to non-pregnant lady. Yes, ma'am.
So my question to you, sir, is the
Hello.
control laboratory. Is there any measure how to ensure quality control at collection sites? In what paper institutes the collection sites will be taken?
Yes, ma'am.
Quality control at the collection site.
Yes, ma'am. We should have the proper SOPs. Wherever, whichever thing we are doing, there should be a proper SOP, and everybody should abide to the SOPs. And there will be there should be education programs. Then on can improve the testing, improve the testing process, and reduce this pre-analytics. Yes, ma'am. Hello.
Clinical correlation is lacking with the result of the test. Usually the blame is put on the laboratory of giving not good results. So, sir, are there any studies which mention how much is the percentage of errors in the pre-analytical stage?
Yes, ma'am. There are different studies which are mentioning most of the laboratory errors are occurring in pre-analytical phase. So different studies are saying from 60% to 70%. They are saying these errors are occurring in pre-analytical phase and in analytical phase around 10% and post-analytical phase around 20%. So most of the error are occurring here in yes ma'am, many studies are supporting this.
Thank you so much. So, I will invite any questions from the audience.
We pharmacologists, I am interested in therapeutic quality. You have talked about the idiom, therapeutic quality. And especially we told that the analysis has to be done within the behalf. Apart from this, are there any precautions to be taken while doing idiom?
Yes, you are not clearly audible, sir. What you are saying? I told that you should not take the sample from edematous side. Then what you would like to know more?
So I idiom, therapeutic quality. I want to ask you the precautions to be taken while doing therapeutic quality.
If not audible, sir. You are not audible.
Very much. We don't have any audience queries. So, I hand over the mic. Thank you. Abhijit, for attending this topic. Thank you, Dr. Ajay Khare sir and Dr. Anna sir for chairing the session. Now, we would like to felicitate our speaker, Dr. Abhijit Nigod sir. As well as online, we will be sharing this screen of module. Since physical felicitation is not possible, we will have a huge round of applause for Dr. Nigod. Now I request Dr. Mahavir Kundra sir to felicitate our chairpersons, Dr. Ajay Khare sir and Dr. Anna sir. Thank you, sir. For the third session, which will be already concluded the presentation by Dr. Indradi Classes. Dr. Indradi Classes will be joining us online. And thank you, my Dr. Shubha Karila, Dr. Chana, and Dr. Mahavir Kundra to chair this session. Shubha Karila, Department of Physiology, Ratnavali Medical Foundation, experience of 28 years.
Hello.
Dr. Anita Satyavarman is a professor at Department of Pathology, Datta Mekhe Medical College, Nagpur, and member of Medical Education Unit, and has a teaching experience of 11 years and has 22 publications to her credit in many national and international journals. Dr. Mahavir Mundra sir is currently working as an associate professor in Department of Biochemistry, Datta Mekhe Medical College, Nagpur, and teaching experience of 7 years. Over to you, sir.
Great afternoon to all. First of all, let me thank the organizers for giving me the opportunity to chair this important session. I am calling this important because today we are living in an era of quality, and that is quality control. All our hospitals, laboratories, institutes, they have to have accreditation status. They have to undergo quality control process. Gone are the days of quantity. We are living in the era of quality control. And same is for laboratories. So I welcome you all for this important session on quality control in laboratory. And to brief you on this session on faculties, Dr. Indrajit Basu. Dr. Indrajit Basu is a laboratory director at MD Healthcare Private Limited at Kolkata. He has been previously associated as consultant biochemist at various labs, for example, Dr. Lal Pathlam, Apollo Diagnostics, Saroj Gupta Cancer Center, Unipath Specialty Laboratory. Sir was an assistant professor in biochemistry at Government Medical University Nagpur for some time. And after his PG, he has done his PG from LTMMC Mumbai, where he was awarded with the first position in the university in biochemistry examination in 2016. The special areas of interest are quality management system, laboratory management, material screening, indirect immunofluorescence, microscopy, and he has got more than 10 national publications through his credit on this area. So please welcome Dr. Indrajit Basu, and it's over to you, sir.
Thank you, ma'am, for the warm introduction. Ma'am, I would be requiring some IT help for doing the screen sharing. Will it be possible?
Yes, sir, it is enabled.
Okay, okay, sir. Hello.
You can share your video.
Yes, ma'am, I have my PPT on my screen. Can you just tell some IT person to help me out that how to connect it to the screen, ma'am?
So please click on the share screen option.
Share screen option.
Yes, yes, the share screen option. Yes, I have chosen and then shared.
Yeah, it's visible, sir.
Is it visible?
Visible.
Yeah, so should I go on the presentation mode? Yeah, is it visible now?
Yes.
Ma'am, am I audible? Hello.
Can start, sir.
Okay, ma'am. I'm starting. Thank you everyone from Datta Mekhe Institute for this warm welcome, and special thanks to Dr. Mahavir Mundra, who has connected me after 5 years working in Government Medical College, Nagpur. So I'm Dr. Indranil Basu, and the topic today in which I will be talking about is quality control in the clinical laboratory, the way how we do. So what I will be covering, am I audible properly?
Yes, sir.
Yeah. I'm just carrying on. Yeah. The contents that we will be covering, we will be talking about the QC and its terminologies. the major thing, that is the precision and accuracy, the internal quality control, ECAS, that is the external quality assurance scheme, verification of performance specification, and some experience to share. Coming to quality control and its terminologies. Now, what is quality control? It is a series of analytical measurements to ensure that the results generated by the test systems are correct. And let us go through few terminologies to understand the process very thoroughly, that what is true value. True value refers to the exact value of an analyte in a particular sample. Sometimes it is it is a very ideal concept, and it is very difficult to achieve. So a more achievable term is an acceptable or accepted true value. That is a value which is very close to the true value with negligible difference within the acceptable units or acceptable limits. Error, and when we call an error to happen, if there is discrepancy between the value of the measurand and the true or the accepted true value. Coming to precision and accuracy, precision, we know that it is the agreement between replicable measurements. Like in the first DART, the typical DART presentation, first DART presentation A, we are getting to see all the darts being arranged haywire. So after repeated dart throwing, it is not coming to any particular point. So the precision after replicable measurement is not there. In the second picture, we get to see that there is precision because replicable measurement have closeness of agreement amongst themselves, but they are not at the bull's eye. That means they are not accurate. So what is accuracy? It is the agreement between the measured value and the true value or the accepted true value, whatever you may say. In the third picture, if we see, we get to see that they are nearing accuracy, but the precision is a bit low. And in the last picture, we get to see that both accuracy and precision are there. So the take-home message from this particular slide is, before getting to accuracy, we have to have precision. Otherwise, the whole endeavor of getting the thing both accurate and precise will fail. Now the coming to measures. When we speak about concepts like accuracy and precision, there has to be certain statistical terminology or statistical numbers which we have to deal with in order to measure the precision and accuracy. One such statistics is bias or inaccuracy, and from the name you can understand that it shows how much a particular measurement is inaccurate, or it can show the level of accuracy in this particular measurement. So how is it defined? It is the numerical difference between the observed value from the target or the peer group value, and it is numerically expressed as the reported value minus the target value expressed in percentage. Like, for example, the SGPT, if we have a reported value of 108 international units per liter and the true value is actually 100, then we have, sorry, it's a typographic error. The bias is 8%. That is 108 minus 100. That is the difference divided by the true value into 100%. Okay, so this is how we calculate bias. Coming to coefficient of variation. Now we talked about accuracy being measured in terms of bias. The precision can be measured in terms of coefficient of variation, and coefficient of variation is basically a standard deviation expressed as a percentage of mean. It is also known as relative standard deviation and is expressed as standard deviation divided by mean into 100. Now, why this CV is preferred to SD? It is because that percentage CV is independent of an analyte concentration. With this example, like this chart shows the mean and the SDs of glucose concentration of a particular control, where one, in case of the hexokinase method estimation, we get to see that the mean is 120 and the standard deviation is 4.8. In the other GOD-POD estimation, we get to see that the mean is 100 and the standard deviation is 4. Now, by isolatedly looking at the standard deviation, we might think that the hexokinase is having a more variation, more standard deviation than GOD-POD. But if we calculate the CV or the coefficient of variation, we get to see that both are at same degree of variation. So here we can compare the degree of variability irrespective of the concentration of the analyte. With these concepts, we are trying to see what internal quality control, how we go about it. The internal quality control is a valuable technique to ensure that the results produced from an assay are reliable and reproducible. We usually there can be many options, but since we are discussing about what we do actually in the lab, so overall in a lab, we mainly use commercially available internal quality control materials, which may be liquid stable, which may be lyophilized. We have to see the kit literature of the particular control, and then we have to means if it is lyophilized, then we have to mix it with some specified volume of distilled water, or means the specified water which is being mentioned in the literature, which can be injection water, or it can be like aquaphor water, and whatever it is being given in the instruction, and we have to mix it for a particular minute, keep it at a particular temperature, and then aliquot it, and then we have to store it as per the instructions. Some specification can be at -20 degrees centigrade, some can be at 2 to 8, as per the literature we do it. And then before and these internal quality material comes with a if they're pre-assayed, they come with a manufacturer range, means in the range in which we are expecting the values to be there, to call our internal quality control exercise to be satisfactory, which in turn will lead to mean that the samples that I am going to process will bear precise and accurate value. Now, with the IQC values, we plot the LJ charts on daily basis. And how do we go about it? Like, we have the Levy-Jennings chart where we plot the mean. To start with, we can plot the mean of the manufacturer on the very first day. If we get to see that it is the mean, followed by 1 standard deviation, 2 standard deviation on the positive side, 1 standard deviation, 2 standard deviation on the negative side. And then when we get the value, we start plotting it across this particular LJ graph and get to see that where are my values centering to? Is it too much away from the range? Is it within the range? How they are behaving, and so. And to understand whether they are outlying or not, we have a set of rules like Westgaard's rule, which frequently we use. So it's a combination of the decision criteria or the control rule and allow determination of whether an analytical run is in control or out of control. It can be used individually or in combination of multi-rule. Useful for detection of random and systematic errors. We will come to these. So the first rule of Westgaard is 1-3S rule. This is violated when single control exceeds the mean by plus or minus 3SD and is applied within control material only and identifies random errors or possibly the beginning of a large systematic error. Here the example we are getting to see in the -3SD, there is one such reading. So it can randomly happen, and if we repeat this particular QC, we might get to see that there is correction. In that case, we might call it to be a randomly occurring error. And still, if it is again on this particular lower side in the next reading, we will be understanding that it is the beginning of a systematic error, and then we have to take for the corrective action. Coming to the Westgard's 1-2S rule, it is called the warning rule. One of the two control results fall outside either plus or minus 2SD. It is an alert for the technicians that a possible problem can happen, but not to reject the run, but to keep it under observation. Coming to Westgard's 2-2S rules, it is the violation within run if two consecutive control values exceed the same limit plus or minus 2SD, violated across the runs when the previous value of a particular control level exceeds the same by 1-2S or minus 2S, detects the systematic error and is applied within or across the run. What we mean by this is basically here you get to see, firstly, we are outlined by 1-2S. Again, in the next run, if we get to see that this value is again coming in this particular range, then these two together on this particular, on the same side, is leading to 2-2S violations. So it is definitely a systematic error which is happening, and it can be in the same level of QC or in the same run in different level of QCs being taken together, and a corrective action is indicated in this case. Westgard 4S rule, when one control measurement exceeds plus 2SD and the other control exceeds minus 2SD. It is a rule which is applicable across control level. For example, my level 1 control is having this position that and my level 2 control is having this position in such a way that the difference between them is 4SD difference. So this will be considered as a random error, and then we have to find a root cause of the whole thing and see if any corrective action could be taken or not. Westgard 4-1S rule, four consecutive QC results for one level control are outside 1SD. Here you get to see these green and yellow points. These 4 points are beyond 1SD. So this is showing a slight bias on one particular side of the QC. Though the number of results are small, this could be the early detection of a impending bias that has happened in the system. Westgard 10X rule, it is detecting bias applied to both within and across control measures, violated across control measures if last 10 consecutive values, regardless of the control levels, are on the same side of the mean. Violated within control material if the last 10 values for the same control level are on the same side of the mean. Here in this picture, we get to see that here all these 10 values are on one particular side of the mean, clearly showing the 10X rule violation, which is presence of a bias. In such a case, we have to see for the means we have to go for the troubleshooting, the root cause analysis, and any corrective action which is there, and we get to see that whether we can eliminate it or not, and whether again run the control and get to see whether our desired value is reached, or otherwise if we are accurate as shown by our external quality control report, then we can think of comparing our mean of these values with the peer data, and then we could shift our mean and see means we can shift our mean as per the peer data or and get to see the performance in subsequent days to understand how the parameter is behaving. Coming to 7T trend here, the trend, it's a gradual and often subtle increase or decrease of the control values and is possible in case of patient results too. It's a type of a systematic error and rejects when 7 control measurements in trend are in the same direction. We get higher or lower progressively. For example, this particular diagram, we are getting to see that they are rising gradually over 7 readings, showing a possible change in the reported value, and this has to be picked up by the system and looked for what is my reagent deteriorating, is my QC material deteriorating over the days and all, and whether water quality is deteriorating, and we have to find an appropriate cause which is leading to this and troubleshoot it accordingly. Coming to the random errors are any random deviation of laboratory mean, means random deviation of a particular result from the laboratory mean. It is to be noted that the SD is acceptable, that 1 SD is acceptable as the random error. It is difficult or almost impossible to eliminate. Like why it has happened at to some extent, random error means troubleshooting a random error or designating it at as random error. Usually we do it when we are not being able to find a genuine possible cause, and if we get to see that we are landing up with too much of random errors, we have to introspect into the system that if we are missing out on particular something or not. Coming to systematic error, it is a trend or a shift away from the laboratory mean. Shift is a sudden and eventually stable change in the control values and possibly the patient values. Avoidable error due to controllable variables in the measurement. Coming to, with this we are entering into the ICARS. Means before going into the ICARS, let me tell you that the troubleshooting, we check the LJ for having the outliers, and we designate it whether a random error or it is a systematic error. And in case of systematic error, we try to find out a possible cause which has done it, that is we call it the root cause analysis, followed by a corrective action and a preventive action as per the situation. And sometimes there is calibration instability. Then in that case, if we are not finding a similar thing, we have to introspect into the system, like when the last calibration was done, what is the stability of the calibration of that particular parameter. And then if we think that yes, it is the time for the parameter to be calibrated, we go on for calibration and then get to see if the control is improving or not. So it becomes very individualized approach from parameter to parameter. Like for example, if we have a deterioration of the water quality, we can get to see that the phosphorus, magnesium, iron, they are affected simultaneously. So that particular pattern will lead me to understand that yes, something is happening with my water quality and I should be vigilant more to see the water supply and the water purification at my end. So it goes on individualized like that. Now the next thing is the ICAS. We are coming to the external quality assurance scheme. It is used to describe a method that allows for comparison of a laboratory's testing to the source outside the laboratory. It is used to evaluate your own lab performance with other reference participant labs. It is a program in which the laboratory participates and receives a blinded sample and composite panel of samples from other laboratory or any organization which is conducting ICAS. The laboratory processes the sample just like a routine test sample and returns the result to the organization laboratory for analysis within the specified time in the designated format. And the term ECAS is also external quality control is sometimes interchangeably used for proficiency testing, but there is a difference between the two. Proficiency testing shows how proficient my system is. So it can be done by doing an inter-laboratory comparison. It can be done by doing split testing. It can be done by doing external quality assurance schemes. So proficiency testing is the mother term, and ECAS or external quality assurance is a subset of it. Now, with whom we prefer the comparison? We prefer the comparison to be done with a peer group of laboratories. Sometimes we define peer as the same platform or having the same method. What do we mean by that? Suppose our lab has this particular instrument for CLIA and I want to compare with our peer. We have to choose the labs which is having the same instrument, having that particular same method, and we go for the comparison. So this type of comparison is known as a peer group comparison. Coming to a method comparison. My lab has got this particular instrument with CLIA method. I am using another platform of a different make, but the method remains that same CLIA. So this is a method group comparison. And mode, I have this particular instrument of CLIA and I am comparing an analyte, for example, TSH, with all other platforms which are available on different methods. Like all these instruments, we can perform TSH, means a TSH performed on CLIA can be compared with other on CLIAs on enzyme linked fluorescence assay. It can be compared with ELISA and so on, and we get a comparison. Obviously, like the way we had in the sequence in which we had discussed, a peer is always better than method and than mode in this particular order. Now, we always think of a statistic in order to evaluate certain things, since we are dealing with quantitative estimation. So for external quality assurance, the statistics is known as standard deviation index or the Z-score. Now here, how do we, this is also a way of measurement of bias. Now I'm coming to the formula. It is the Z-score is actually the reported value minus expected value divided by the comparison group SD. What does that mean? Means the difference of value from the expected value. Please consider, we had talked about the true value and the accepted true value. We can consider this expected value to be something like that, with which we are having the comparison. So how many SDs, means there are many labs who have given a particular TSH value. So how much it is deviating, the difference divided by the whole comparison group SD will give me how many standard deviation away is my own value from the expected or the true value. And how do we interpret it? If it is -1 to +1, it is called as excellent. If it is between ±1 to ±2, it is good. If it is 2 to 3, we accept with a caution and call that as a warning signal. And beyond 3, it is unacceptable. This is how a typical Bio-Rad ECAS look like, this ECAS page, and how do we go on for interpreting it. I'm just splitting this report into two halves for the understanding, we are getting to see that here the lab details and everything is being given, and the value that I have reported is present over here, and it is being compared with what we had mentioned, the peer, the method, and all results, that is the mode comparison. So here we get to see how many labs have reported in this individual group, what is the mean, what is the standard deviation, what is the CV, and what is the uncertainty of the peer values that we have got. And now with my result into picture, a Z score or standard deviation index is being considered, which is coming out as 1.25. It is the percentage deviation which is being shown, and the average of last 6 month standard deviation means the last 6 month Z score average is shown as RMZ, that is root mean Z score. Okay, now here we get the graph, and in this graph we get to see that the peer has reported like this in a normal distribution, and where my particular result is in frequency distribution. This is the upper part of the report, and in the lower part we get to see a trend analysis, like in this last year, how my glucose level has performed over the Z score. Starting from here, we get to see from April to March. So here, how the values have performed. And the lower graph shows the plotting of Z score across concentration. Means this is lower concentration to higher concentration, and where my Z score is lying within this particular range. So this completes, and on this right hand side we get to see that all different platforms where we have, where the if we have a peer like Roche or Beckman or Vitros, all these instruments, from all these instruments, glucose has been estimated by different methods. So how many these individual platforms they have reported, so that cumulative list is there, and then we can understand by individual report that where we are lying. Coming to how to avoid errors, while configuring a particular ICAS in a particular web portal, which can be a Biorad website or a CMC Velour or an AIMS, we have to see to it that we are putting in the correct classification of the testing methods, the correct units, the correct sample to be tested. Sometimes there is the plasma or the serum we have to specifically mention. There should not be any transcriptional error, and there should not be any technical error. So these are points of errors which can which we need to avoid. And troubleshooting and corrective action like this, we make a means troubleshooting checklist, where if we are having a ICAS outlier, we first relook into that particular day's IQC data, whether it was okay or not, whether are there any trends in the analysis of the ICAS, like the way we showed in the graph interpretation. Is there any change of the recent change of the reagents or the calibrator? Look for the acceptance of the testing details, the lot verification, whether the reagents and the calibrators have been stored properly or not. What is the water quality and the change in the environment? Has any new operator who has done the thing so that there is no technical error or so? And investigate for the and we have to go for the investigation of this particular issue and go for the troubleshooting, followed by troubleshooting and followed by the root cause analysis and corrective action, preventive action. And lastly, when we have done one corrective action, because usual frequency of the ICAS are basically something like once in a month. So if I am outlying in the ICAS in 1 month, then whether the corrective action is what I have taken is right or wrong will be evaluated in the next month if we wait for the ICAS. So we do a inter-lab comparison from a nearest lab, preferably a peer group comparison, having the similar instrument, similar platform, to know that what we have instituted today is correct or not. Sometimes in the troubleshooting of ICAS, people say that oh, our ICAS is outlined, we will do ILC. No, the thing is you have to do a troubleshooting followed by root cause analysis, corrective action and preventive action, and whether the step that we have taken is right or wrong will be said by a ILC. So ILC is mostly the last step of a ICAS to know whether the ICAS outlier has been provisionally corrected or not. So that should be the take-home message from this particular slide. And with that, we discuss about the benefits of the ICAS. The benefits of the ICAS is that it provides a comparison of the performance. It provides early warning of the systematic problems. It's an objective evidence of our testing quality, the areas where we need improvement. It can detect whether training is required or not, and it is a sort of tool to understand whether we are maintaining long-term accuracy. Last and not the least, it is required by accreditation agencies. It is one of the main criteria of having an accreditation. So these are all the benefits of ICAS. Coming to a real life example of troubleshooting, which I have come across to share with you. Like this is a last page of a Biorad ICAS, where we are getting to see that from month 1 to month 8, we are having very many outliers. Some, and this yellow are warning range, and this red shows these are unacceptable range. So we are getting to see throughout this particular frame of 8 months, there are many outliers. And on looking into the IQCs, we are getting to see that, okay, it is almost okay. There are variation, but the charts are looking almost well and good. Now, we introspected into the water quality, we introspected into the reagents and the storage condition and everything, and we were not being able to find what is it that it is causing the whole thing. Now, then suddenly we started looking into the calibrator, and we got to find that after this first month, there has been a change of the calibrator lot. And what was found out was that the assigned value, when the calibrator lot has been changed, the assigned value has not been changed for all the analytes. Means on on asking the technician, we got to find out that the technician, being junior, has compared the creatinine calibrator value of previous lot and the new lot, and total bilirubin calibrator assigned value of new lot and old lot, and he found that they are coming close by each other, and then they have got for then they have assumed that all the parameters will be having similar values, and they have used it for 8 months, and they are coming up with this sort of an ICAS. And after and on the 8th month you get to see that after the proper assigned values being assigned in particular thing, on the 9th month when we are running the ECAS, we are getting to see that there are no outliers. So things could be that tedious, means while troubleshooting it has to be means the troubleshooting checklist has to be so much meticulous and extensive that we should not be missing out what is there, because the technical staff and the people associated with the lab, they have taken into consideration that whenever the calibrator is being changed, obviously the assigned value has been changed. So for these 8 months they were under the myth that this is not to be seen, and it took 8 months to do this corrective action. So I shared it with you like as a example of a corrective action that is being taken and how the results show on face that the corrective action that we have taken is right or wrong. Now coming to the verification of performance characteristics, NABL 112 document on based on which we prepare our labs for NABL accreditation, it says that verification of all automated or semi-automated system is required to include precision, accuracy, carryover, wherever applicable, and linearity. Coming to precision study, what we actually do, we precision check is repeatability is done in 5 replicates at 2 minimum level, and it is done at least once in a year or after a PT failure, PT that is proficiency testing failure, after a major repair, and if QC is indicated, and it should be less than the allowable or the scope CV. Carryover, we are getting to see whether in my instrument after assessing one high value sample, if my instrument is having another low value sample, so is the high value being carried over to the low value, and is there any affection of reporting the low value? So that is my aim, to understand the carryover, to do the carryover study. Here duplicate measurements of high sample like H1, H2 in sequence is done, followed by triplicate measurement of L1, L2, L3, means the low sample being taken into 3 aliquot, and this is a high sample taken into 2 aliquots. So the sequence is H1, L1, followed by L1, L2, L3, and the calculation is done by difference of, like, if a high sample is affecting, it will be affecting my L1, because after H2 it will be coming to L1. So difference between L1 and L3 divided by H2 minus L3, means the highest value minus the lowest possible value if there is a carryover, expressed in 100%. The carryover percentage should be less than the allowable bias or as specified by the instrument manufacturer, and these are performed biannually or annually as per the quality protocol of the lab which is being set. Coming to the linearity study, it is the analytical measurement range of an analyte. Sometimes means actually what we do is we take a high sample and then we keep on doing a dilution of 1:1 dilution, 1:2 dilution, 1:4 dilution. Like that, we can go up to 1:32 dilution depending upon the value that we are getting. So we try to calculate the calculated value after the dilution of these particular samples, and we plot a calculated value versus the actual value that we get by processing the sample on the instrument. Now, it should ideally bear a straight line amongst each other, having a slope of 45 degrees. So that is the acceptable criteria for the linearity study. Now coming to till now, what I have discussed with you here is more or less available in any sort of quality control training or any sort of quality control exercises. But I'm here to share few experiences with you and the things how actually we face and how we overcome such situations in the clinical lab in day-to-day practice. First point, what I have understood in my experience of the lab development is that quality should not be a myth. How do I give an example? Like, for example, linearity. So if my sugar means in case of a particular reagent of hexokinase, we are getting to see that sugar is having a linearity from 2 to 750 milligrams per DL. So there are myths amongst the people who are working that we have to get a 750 or a 720 sample to do the linearity. So no, we have to get a high sample. Maybe we are not getting a sample of a 750 value. We are getting a value maybe 500. You go ahead with doing the linearity with which you can plot the graph and do the thing, and you say that the linearity to which this particular experiment has checked the linearity of this particular analyte is 500, and when we will get a sample of 750 range, we will go ahead for doing the linearity. So that's how we mitigate. We should not be like, quality gives us rules and statistics to move forward, but we should not be bewildered by the numbers only, that we have to hit that particular target to get it done. Otherwise, we won't be able to do it the time when it is required. So that is what I mean by that. The quality means the rules of the quality should be followed stringently, but how you are going to implement it, you have to be very lenient as per the scope of your laboratory, as per the situation demands. Another point which I till like my first NABL, I was very much tensed with, was that what should be the acceptance limit? Should I go to like CLIA guidelines? Should I consider the biological variation guideline? Should I? There are really bad guidelines. If you go to Westgard site, you will get to see many guidelines which are there. And in India, there are guidelines which are, there is no specification of the guidelines. If you go through NABL 112 or ISO 15189, it says that what is to be done, but it does not say how it is to be done. So in the initial years before my first NABL, I had to toil hard that what is to be done and what is to be done. And finally, what I get to see is we have to create our own data to set our limits. Means initially we start plotting our LJs. Initially we do not give a stringent cutoff at the very beginning. After 6 months of performance, doing proper quality control, doing proper ECAS, we get to see that what is my achieved CV. So from that, what is my highest CV? So that I am achieving. So for upcoming next 6 months, that would be my target. I will try to be within that particular limit, and then again revise after the next 6 months. So it should be, means we have to create our own data. From our own data, we will be able to understand what limits we will be doing. And obviously, whenever we are going for estimation of such a thing, whether if we are actually following the CLIA guideline, or we are deriving our own data, how we are doing it has to be properly written down and documented in the quality system procedure manual, so that there is no ambiguity in how the process is being done. that is what I mean by create your own data to set your limits. Then we discussed about LJ plotting, and there are Westgard rule, and LJ plotting is one of the means by which quality assurance and internal quality assessment can be done in a clinical laboratory. But if we go and read the recent version of NABL 112, it has given the lab the liberty to choose any method which is validated and to be considered as their particular quality control protocol. Previously, they had mentioned like Westgard's 1-2S rule, 2-2S rule for 1 level quality control. These are to be followed. For 2 level, these are to be followed. Now they have taken up that particular paragraph and they have said that they have mentioned the frequency that minimum 2 level of controls to be run irrespective of the load of the analyte on the particular parameter. But how the lab will interpret is the lab's decision. So there are apart from LJ plotting, there are statistics like sigma matrix calculation and sigma matrix based control Westgard control rule application. So that can be considered. Some labs are using like automated instruments where moving average of the mean that is being considered from the sample, which is acting as a real-time QC for the samples. So quality process should be progressive. That is, we should be trying out with different statistics to understand that which is suiting my purpose. But for all practical purpose, the simplest and the most widely used is being LJ. But side by side, in order to do progress in quality, we should go ahead for at least finding out the sigma performance, sigma metrics of the individual parameters, and get to see that if we can apply the corresponding rules as per the sigma metrics, so that we can derive a level of quality a bit ahead than before. Another point that I would like to discuss with you is that quality should not be a one-track approach. It means whatever we are doing is for the patient data and patient reporting, and what we have to clinically correlate. Some means there are some procedures like in labs, we get to see that there are specific recheck criteria. For example, I'm giving an example like if a lab sets up for recheck criteria of TSH being all TSH beyond 50 will be repeated. So now the point becomes like in a patient where I am getting to see that TSH is more than 50, I am getting to see a prescription of the patient having a history of hypothyroidism, and the doctor has mentioned the last month TSH is there, and I am finding an FT4 value of that same run is clinically corroborating with a 50 TSH along with the previous values. So in that case, I can easily not go by rechecking that particular TSH by that recheck criteria. I'm applying my clinical knowledge and taking the history and previous data and corroborating clinically, and then I can go on releasing the report. So we have to keep on in mind means why are we doing this quality procedure? It is for ultimately for the accurateness and the preciseness of the patient reports that we are generating. So, and when it is a patient report, a doctor has the full liberty to use their clinical knowledge from in that case, and that can actually reduce a laboratory's recheck load and all. Similarly, critical alert. Like critical alert, people means there are references of critical alert being there in different books we take that reference, and if we blindly follow that, it might not suit our purpose. If I am sitting in a lab of a cancer hospital, there the critical alert for cancer markers will be different than a general lab who gets general screening samples. So you have to take critical alert from the references that we are having, judge the clinical situation and the lab and the hospital where you are working with. You can talk to the clinician, you can have a idea of the requirement, get validated the new critical alert range which you are choosing and a possible explanation, sign it and apply it for your purpose. A lab which is associated with a kidney transplant unit, if in general labs we check recheck creatinine if we get beyond 5. So if in a kidney transplant unit lab, if it goes on rechecking all creatinine beyond 5, they will end up doing double tests. So it has to be prioritized as per the means the situation. That is what I want to say. Finally, the quality should be in the entire process. Like in my previous presentation, Dr. Abhijit has mentioned about the pre-analytical process and all, and I have emphasized on the process which are there associated with the analytical phase, but it is very important that how it is to be applied to the entire process. I'm giving an example of an add-on sample, like the clinical laboratories, they retain sample for clinical biochemistry minimum is 24 hours. Some laboratories keep for 48 hours, some for 72 hours as per their own protocol. And whenever a parameter like sometimes there is request for add-on on a particular sample. Now, if for parameters like TSH, I can add on to the next day. Means because they are that parameter stability is there. Now, if we add parameters like vitamin B12 or vitamin D, which are light and temperature sensitive, then we will definitely get a low value for that patient sample. Now, irrespective of how much quality control procedure you maintain, how narrow CV, how good ECAS, you are definitely going to report a wrong value for a very low value for vitamin D or B12 if the sample is exposed to light or very difference of temperature. So a lab needs to make its own criteria of parameters which can be added on the first day, which cannot be added on the second day, like that. So that there is a clarity to the the people who are working in the lab, that what is to be added and what not to be added. So the quality and the information has to be there in the entire process to ensure quality results from the lab. That is what I would like to mean by the statement. And finally, the reward for the quality is actually generating flawless report for the patient and successful communication with the doctor. Because if we are getting to see a high value or a low value which we are really not expecting in that particular patient, we should be very vigilant to take the history. We should be very vigilant to contact the patient or the concerned doctor, ask for the prescription, to correlate, and from somewhere or the other, in my experience, I get to see that we get to find a possible explanation. I can give you one example, like like last week only, I got a sample of a 16-year-old boy. I'm getting to see that all parameters are normal, but I'm getting to see a bilirubin on the means total bilirubin is more on the higher side, and it is showing unconjugated hyperbilirubinemia. Had it been a newborn child, okay, unconjugated hyperbilirubinemia is there, but CBC picture, everything is okay. So I had a doubt, and I asked for the history, and the doctor mentioned to me that this patient is having Gilbert syndrome, where this particular picture is very common. So some way or the other, we have to be we doctors have to be, apart from the quality control, the statistics and everything, the whole motto is to generate a correct report which is medically correlating with the patient's clinical status. So what might the take home message from this thing would be, no matter how much we implement statistics or quality and improve in from LJ to sigma, the moving average and recheck and everything, ultimate goal lies in generating correct report for the patient, and for that we have to be vigilant to ask for the history. And believe me, in corporate labs who are fetching samples from clients, who are getting samples from their the collection centers, we do get history. If we I have data also, like if we ask for 100 histories, we get 70%. So that is genuinely a good number to start with, and we try to improve on that, like the way we do for quality. So at the end of the day, it is the patient service which matters to the most. So covering the pre-analytical, analytical and post-analytical response in this order. And at the end of my presentation regarding quality, I would like to acknowledge my mentor and guide, Dr. Pramod Ingle sir, Professor and Head Biochemistry Department, Lokmanya Tilak Medical College, Mumbai, who has infused me with this query for the quality, which I am trying to find out in my native place, working in different labs and being associated with NABL and all. And I would like to acknowledge Dr. Mahavir for connecting out to me for this particular webinar. And I acknowledge Datta Meghe Institute of Higher Education and Research. And in the audience, I can get to see a lot, many seniors and juniors of mine from Maharashtra. I would like to thank them for attending this session and be a patient listener to me. And I would like to thank you all. Thank you.
Thank you, Dr. Ravi, for a very knowledgeable session on the quality control. I would like to ask one question that how many control samples should be run in an ideal scenario for internal quality control?
Sir, your voice is very echoing. Sir, can you please write in the chat box, or can you just reduce the level of echo so that I can hear?
How many control samples should be run in an ideal scenario for internal quality control? And how many times in 24 hours?
Sir, you are, if I'm getting it right, you are asking for the frequency of the control, means how many controls we should be running, right? Yes. Yeah. How many controls in a particular day? Now, sir, if we talk about the NABL guidelines, the recent guideline says that at least 2-level controls to be run irrespective of the load. Means if you are running one sample also in a particular day, you have to run 2-level control, one normal and one pathological range control that is there. And if your lab is working 24 hours, then additional controls to be added 8 hourly. So how do we go ahead in a 24-hour lab is we perform like in the morning we start the instrument, we go means considering that we are having the load throughout the day, okay, uniform load throughout the day, because we are working in a either hospital lab or in a corporate lab where samples are continuously coming. So what we do, we switch on the instrument, we run 2 levels of control, check for the performance, take the corrective action, that is the level 1 control and level 2 control we are running in the morning, and we are starting the after proper action we are going for running the samples and all. After 8 hours from that particular time, we are running again level 1 control only and getting to see if there are any outliers or not. And 8 hours from that, we are again running means level 2 control. Previously we had run level 1 control in the afternoon, then in the night we are running level 2 control and getting to see that whether any deviation is happening or not. And the next morning again, when we are switching on the instrument, the 2 level controls. So 2 1 means 1 2 together followed by 1, then level 2, and again in the next day the same cycle repeats. So that can be one way of doing it.
Thank you. Thank you.
You've covered all the aspects of quality control in clinical laboratories. And very well presented. And I will inform our understanding concepts and congratulations and many thanks for great presentations.
Thank you, ma'am.
Thank you, Dr. Indrajit Basu, sir, for the discipline to talk on this topic. Thank you, Dr. Shubhala Gade, ma'am, Sachina, and Mahavir sir for chairing the session. Now, I would like to felicitate our speaker, Dr. Indrajit Basu, sir, on time during the sharing the script. And we will give him the momentum as to the presentation. I request Dr. Ananta ma'am to felicitate our chairpersons, Dr. Shubhala Gade ma'am, Dr. Anita ma'am, and Mahavir sir. Thank you, ma'am.
Thank you, ma'am.
The next session on advancement in clinical chemistry, autoanalyzers, and clinical laboratory improvement commitments. I would like to invite Dr. Suresh Chandrasekhar sir. I would like to invite Dr. Janak Karima, Mahavir Mundra sir for chairing the session. Joining soon. Dr. Manju is the associate professor and ex-engineer, particular biology at the Medical College, Nagpur. That was the past history. Back to studying the other applications to the national and international journals. Dr. Mahavir Mundra sir is currently working as associate professor in Department of Biochemistry at the Medical College, Nagpur, and and has a teaching experience of 7 years. Dr. Nandakishore Bankar sir is also associate professor in Department of Microbiology, Data Medical College, Nagpur. Has a teaching experience of 10 years and has many publications in this field in many national and international publications. Over to you, sir.
Thank you, Rashmi. Good afternoon, everyone. Let me take this privilege to introduce our next speaker. He is Mr. Suresh Chandra Shekhan. He is going to enlighten us regarding the immunoassays on TILA. Mr. Chandra Shekhan is having a vast experience of 28 years experience in IT industry. He had various positions across the world in different verticals of the sales, marketing, business development, and knowledge management in South Asia and Americas. He is co-author in various books where an insight into like indicators and so on. He was associated with not many diagnostic companies now, but right now he is with the Beckman Coulter Diagnostics. Along with that, he has launched so many programs, so many markers related to the immunoassays. One of that was the autoimmune diagnostics in southern and eastern India in 2000, and the novel sepsis marker across the pan India that we launched for the procalcitonin. Along with that, early rheumatoid arthritis markers in 2003, and also we conducted first conclave for South Asia along with launch of profitable. So let's please welcome our speaker, Mr. Suresh Chandra Shekhan.
Thank you. One second.
So am I audible? Okay, perfect. So then I don't require a mic. Okay. I know that we are having the pre-lunch session, and there's a famous saying by the Tamil poet Thiruvalluvar, which goes like this: if you do not have food for your ears, you do not have food for stomach. I mean, basically it says like saving to one that's what Thiruvalluvar told 2000 years back. So I request you to keep some of your neurons active to listen to what we are going to talk, and mainly on prenatal screening. Before that, I thought we will just give a brief introduction of Beckman Coulter Diagnostics. So Beckman Coulter Diagnostics is something related to elevating the performance through which we advance the patient care, and our mission goes like relentlessly reimagine healthcare one diagnosis at a time. Beckman Coulter is part of Danaher, and the Danaher group, just briefly, I mean, this is a loaded slide, just wanted to tell you that we are into life sciences through many companies. I mean, you would have heard Cyclima, PAN, Leica, Biosystems, Leica Microsystems, and all these things. And we also have diagnostics, again with Beckman, like Radiometer, Hemoq, and we have the environment and applied science. And we are present all across the lab through the various opcos, including CIFI, including Leica Microsystems, Leica Biosystems, Radiometer, etc. Just to give a brief, we follow what we call as the Danaher business system for our internal company employees, which is actually rewarded by Harvard as well, considered as one of the best methodologies to improve oneself. I mean, we keep learning as a continuous process. We keep learning as a continuous process, and it's a continuum. I mean, like, if I have to say it shortly, I mean, like Pele said, the goal which I am going to score tomorrow is going to be the best goal of my life. So from that perspective, we keep learning. So talking about Beckman Coulter, I mean, this is two big scientists. One is Arnold Beckman and Wallace Coulter. Over a period of time, they launched many systems between 1925 till so many years. And in 1998 was when Beckman and Coulter merged to form Beckman Coulter Diagnostics. And in India, Beckman Coulter is present as an entity since 2004. And you can see, I mean, you already have many of the Beckman systems here, including our chemistry, immunoassay, and hematology. We like it for that.
And in India, we are present with many systems, close to 5,100 institutions, 1,500 plus clients. Then we have 6 office locations, 78 channel partners, and we have 278 associates, 107 engineers, 45 application specialists. And apart from this, we also have the world's global development center for R&D for the IT. When all our instruments, software is developed in India, in Bangalore, and we have close to 300 employees only for developing the software part of it for all the instruments. So that is based in Bangalore. So whenever any of you are coming to Bangalore, do let us know. We will show you around the place. So coming to universities, because universities is a favorite topic, and as Anne said, last 29 years, I have been running university meetings, living and working in universities, if I have to say. And in Beckman, we have access to the system is there here and scalable because for 100 test group, we have access to, for 200 test group, we have the EXI 600, and for the 400 test group, we have the EXI 800. What about the assays? I mean, what is Beckman's commitment towards assay development? Of course, my colleague Jagdish will be talking about the chemistry part of it, but just to give a brief here, in the last 3 years, we have developed more than 50 assays. Most of them, around 8 of them in chemistry and 7 of them in immunoassays. Predominantly, calcitonin was launched in 2019. Active B12, C-peptide, which is again used for the diabetes marker. Then the SARS-CoV-2 antibodies. AMH advanced for the variant hormone. Beckman is synonymous with AMH for the past so many years, and we also have the HIV combo which has been recently launched. And we launched BNP as well. I mean, BNP was the middle that has come in now, and it's a marker where we have clear advantage as well. Though it has a shorter half-life, it can pick up even in case of the nephrological samples. That's a major advantage which we have with the BNP, because NT-proBNP has a longer half-life, but in case of nephrological sample, it does get elevated. Because the reason is, I mean, NT-proBNP goes out only through the kidneys, whereas BNP goes out through all the 4 different organs. So this is our complete menu. We have a complete anemia panel, which includes ferritin, B12, folate, RBC folate, erythropoietin, etc. And we have the complete fertility panel. I'll be deep diving into the fertility aspect during the next part of the session. Then cardiac panel, as I mentioned, HSTNI, then BNP, then CKB, Johnson, myoglobin. And we have the specialty panel, which includes the cortisol, calcitonin, insulin, etc. And we have the complete thyroid panel, which includes not only the thyroid markers, before, but also the TPO, the thyroid peroxidase and thyroid antibodies as well. And we have the IDBG, infectious disease and blood types panel as well, and tumor markers. Notable among the tumor markers is we have PHI, that is the prostate health index, which helps to differentiate between the prostate cancer and the prostate infection, because we are having not only PSA and we also have a P2 PSA, which helps you to identify whether the patient is going towards cancer even before a biopsy. So that's one advantage which we have with this marker, especially for urologists and uro-oncologists. This is a marker of choice in recent years. And we also have the skeletal muscle panel as well. So now I dive into my topic. I know that I have 30 minutes time. I have utilized around 7 minutes, probably now 23 minutes more. And we'll talk about Down syndrome. Down syndrome, if you look at it, I mean, there are 3 different syndromes which we look into when we look at prenatal screening. In 1862, Dr. N. Down identified the Down syndrome because he found this for trisomy 21. That is, instead of a pair of chromosomes in the 21st pair, we have 3 chromosomes. That's the reason Down syndrome is called trisomy 21, and it was also called, in those days, it was also called Mongolian PTSD because of the flat face of the baby, of the fetus. Because of the flat face of the fetus, it was called Mongolian PTSD, but Of course, today, because of the racistic attitude towards the name, they have removed the Mongolian in the name. Apart from, I will talk about the other syndromes later. Down syndrome is seen in more than 700 births in the world. In India, earlier, if I have to take in 2005 2006, we had 1 in 1,000. But along with when we all have been what we call as a single bullet cord families, where the husband works and the spouse stays at home. But over a period of time, we have become a double bullet cord family, which means there is, everyone is career oriented, which means the maternal age gets increased. So when the maternal age gets increased, the risk goes higher. So that way it has become 1 in 800 now, and more than 60% spontaneously aborted, 20% of stillborn and facial appearance permits the diagnosis, and marked muscle hypotonia, single part mark increase may be seen, and learning difficulty is seen, and congenital malformation of the seen. So apart from this, the 2 other syndromes are the trisomy 13 and trisomy 18, which is basically the Patau syndrome and the Edwards syndrome. In both the cases, again, in the trisomy 13, you have 13 pair, you have the chromosome, and the same in trisomy 18. So, talking about Down syndrome, because it is trisomy 21, that's the reason if you see 21st March is considered as the World Down Syndrome Day. It is remembered as the Down Syndrome Day to commemorate the trisomy 21. 21st March is considered as the Down Syndrome Day. It may be seen with the increase in maternal age, because as the maternal age increases, the risk is very high. And trisomy is a type of Down syndrome which results in an error in meiosis and has a recurrent risk. This is what we are seeing. So you can see here clearly 21st pair of chromosome, this is the karyotype image, and you can see here very clearly that 21st pair of chromosome is having 3 chromosomes. So what is prenatal screening? It's the process of determining the chances of a pregnant woman having a baby from a chromosomal abnormality, and the factors dependent on whether we are seeing the various factors are there, whether depending on the race, depending on the smoking, depending on the diabetic patient, the diabetes level of the patient, whether the patient is having hypertension, whether they have earlier had a Down syndrome baby. All this is what they look into. I will show you the different factors which are involved with regard to the Down syndrome in the coming slides. The age of the mother, time delivery, population prevalence, specific measurement of the fetus, then subpopulation. I was telling you about the diabetes mellitus status, the smoking status, and whether the patient has asthma. The prenatal screening does not determine whether or not the baby is having a birth defect, but it calculates the risk, whether the patient is having a risk towards it. And it's like, for example, if I have to draw a parallel, when you do an ANSP, you find patient is having ANSP, but if you want to know which nuclear antigen is affected, you do further screening. So that's exactly what we are able to do here. We are able to identify whether the patient is having a risk or not. And if the risk is higher than the predeterminedly accepted level, then we can recommend, depending on which week it has been done, whether it has been done in the first trimester or second trimester, we can suggest either the amniocentesis or the chorionic villus sample. So for most women, prenatal screening is done in the first trimester and second trimester through the biomarkers and also the ultrasound, which is done in the first trimester. Ultrasound has to be done between the week number 11 and week 13, 6 days. So what is the process mapping? We do the ultrasound between the 11th and the 13th week. Then we do the blood collection for the first and second trimester. 2 samples are collected in case of the composite screening, first one in the first trimester and second one in the second trimester. Because the composite screening is something which is of greater help in identifying the risks now. And based on the lab report, they may suggest doing further testing. So if I have to draw a risk mapping, this is how the risk map goes. The pregnant lady visits the physician, and then they do the ultrasound part of it. And after that, the serum markers are done. The total beta HCG and PABPA, total beta HCG or free beta HCG and PABPA in the first trimester. And in case of the second trimester, it is alpha fetoprotein, total beta HCG, unconjugated histiol, and inhibin A. So earlier they were doing triple marker, which is AFP, HCG, and unconjugated histiol, but now we do the fourth marker as well, that inhibin A. So based on that, we get the graph, and depending on whether the patient is having a risk or not, if the risk is seen, then they suggest either the amniocentesis, CVS, or chordocentesis. So what do these mean? The most common abnormalities are screened for Down syndrome and trisomy 18 and OSP, that is the phenotype. So in case of amniocentesis, what we see is we do the testing with the amniotic fluid, and then we are through the ultrasound, and it's an invasive test. So the chances of risk of miscarrying is there between 0.3 to 1%. And in case of CVS, again, the invasive method to identify the chromosomal abnormality, then we do either the amniotic or fluorescent in situ hybridization. That is, fish, what we call as fish, then it is done along with the fluorescent isotrypsin. When the cells are being divided, the metaphase cells are taken, and then we check for the chromosomal abnormality. And chordocentesis, again, the risk is 1 to 2%. Again, it's an invasive methodology. So this is how you see the fish method as well. Of course, this requires completely fluorescent microscope and automated fluorescent microscope, because it is using multiple dyes along with FAC and other dyes, because of which you see the different colors in the cell depending on the presence of the chromosome, the 21st pair of chromosomes. So how do we do this testing for the immunoassays? As I had mentioned, we have the different systems already available to us, the access the DHA600 and the DXI800. Depending on the load of the hospital, we can look at doing this in the different systems. If the load is higher, with the 400 test input, we can do with the DXI800. If the load is medium, then we have the DXI600. And for low to medium levels, that is up to 1,000 tests per annum. 3,000 tests per month, we can do with the access to itself. So what is the menu available? Beckman has one of the widest menus for the reproductive biomarkers. We have AFP, estradiol, FSH, that is the FSH, NH, then progesterone, prolactin, testosterone, total beta HCG, unconjugated histiol, DHEAS, inhibin A, SHBG, PABP, that is the pregnancy associated plasma protein A, and AMH, antimalarial hormone. So AMH helps us with regard to the, in case of IVF, AMH comes of a greater utility to find out the number of eggs female is able to ovulate. We are able to identify that through AMH, and it comes of a great utility during IVF. Apart from that, during first and second trimester, these are the markers which are used. So you may have a query: what's the difference between a total beta HCG and free beta HCG? Because in some cases, in case of the fetal medical formation, they suggest free beta HCG as a tool. Whereas American College of Obstetrics and Gynecology tells you can do either total beta HCG or free beta HCG. I'll come to it later, explaining the advantages which total beta HCG has over free beta HCG as well in the coming slide. So the characteristics with our assays, the first thing is that our onboard stability is 28 days. We come with a convenient 50 test pack. So a 50 test pack is valid for 28 days, which makes it very convenient. Even if the lab is having 2 or 3 samples a day, then they can manage the workload in 28 days time. And we also have a calibration stability of 28 days, but it doesn't mean every 28 days you have to do the calibration. As long as it's the same lot which you are using, the calibration is stable. Up to 3 months, you can use the same calibration. And we use a 6-point calibration, which means the calibration is being done at your conditions. It is not like, if I have to draw a parallel, many of the companies offer what you call as master curve, and then they just ask you to do 2 calculators. So that is like when they give, when a car is being showcased, they say 25 kilometers per liter. But when you drive in Nagpur, it drops down to 15, and it is bigger in Bombay, it becomes 10, because the condition is varying from factory, right? So they put under test drive condition. So like that master curve calculation is done in factory settings, which is either in US or Europe or China, which are all cold countries. Whereas here we have at many places, I mean, of course, Nagpur has a colder climate during winter and super hot climate during summer. But many places it is only having hot water and hot ice. And we do not know what is the ambient temperature. So depending on the ambient temperature, we are having that calculation done at your lab conditions. So here is the interesting fact of why total beta density. If you look at it, between the 8th week onwards, you see the total beta density. I mean, first after 5 weeks, it starts activity. From 8th week, it starts coming down till the 22nd week. So that's the advantage which you have in total beta density, which you can use over first and second time. In case of PABPA, you can see it going like this between the 8th week onwards, you see it increasing. So, and PABPA is a more important marker than beta hexagon, because PABPA constitutes almost 80% of the contributes. Then we have other markers which are used in second trimester. That is, one is AFP. You can see AFP results here. Then you can also see clearly that the inhibin A here, and you can also see unconjugated history of values here. This is how the normal samples behave. What abnormal samples do? Abnormal samples go in the opposite direction. So we have also created what you call as, I mean, both these things were created by us so that it becomes easier for the laboratorians and the clinicians when they are doing the assays. So what happens? We have done a permutation combination of the different values. So if AFP is low, unconjugated histione is low, and HCG is high, then it can be Pfizer 21. Again, depending on if there is an overestimated gestational age, then also you see the same results. And if AFP is low, unconjugated histione is very low, and HCG is high, you see Pfizer 80. If AFP and UUP are very low and HCG is negligible, then it is a non pregnancy. AFP is initially high, then low, very low, and very low HCG, then it can be a fetal device. AFP high, unconjugated histione, and HCG not seen is open spina bifida. Then you have AFP normal, unconjugated histione undetectable, and HCG normal. Then it can be placental surface efficiency, SLOS as well. AFP very high, unconjugated histione very low, and HCG low. It can be anemocephalic. So why total beta HCG or free beta HCG? If you want to look at it, you can see here. It depends on the temperature at which the sample is transported. If you are getting samples from outside, if a typical lab is getting samples from outside, or the samples coming in ice packs. If the samples are not coming in ice packs, then chances of the sample getting deteriorated is very high for free beta HCG. Free beta HCG values get elevated, because of which you will have what you call as patients being given false positives for Down syndrome. So this I have seen personally in the last 17 years. So that's the reason I want to highlight this, because this is a typical condition in India where we need to be aware that in case of Down syndrome, sample transportation is very, very critical in case of free beta HCG. And we have the studies to do. So coming to Down syndrome per se, I mean, just to give a build-up here, India as a country, we have what it has 28 million births per year. I mean, in early 2000s it was 28 million, today it is 27 million. The total number of tests which are being done for Down syndrome, first and second trimester together was only 5 lakh tests way back in 2006. Today it is around 40 lakhs. That is only 4 million tests are being done against 27 million births, which means only around 15-16% of the patients, of the to-be mothers are tested. The balance 84% of the to-be mothers are not tested either for first or second trimester. So that much more awareness needs to be created. This is the input data which I have based on that data. We also have the software for this. I mean, we have the Benedict software. This is a Canadian software, and this is a tool which is used for diagnosing the Down syndrome. I'll tell you why it is important. The screen is very important. I'm just going to the software part because of the paucity of time. So we have the versions of the software, the basic, which gives only the basic version, and we will be looking at the composite version because that gives you for both the first and second trimester, and it is the most important part of it. I mean, we have more than 140 users in India using the Benedict software. That's the major advantage with this because we have Indian MOEMs loaded on the software. In most of the software, when you have Astrea, you have Viewpoint, you have SSTW, and you have Triska, and other software as well. But most of them use what we call as a Caucasian or Asian MOEMs. Here we use Indian MOEMs. And today we are at the cusp of developing zonal MOEMs as well. That is, if you are having a patient, I mean, you can go to the level of the surname of the patient. If he is a Reddy, you can classify him south. If he is a Sen, you can classify him east. If he is a Shah, you can classify him west. Like this, I mean, we can go to the level of classifying them in the respective zonal MOEM level. This is something which we will be introducing in 2023. So that I mean, we are closer to the result perspective. Because I mean, each thing is, at the end of the day, the closer we are to the base of the person, it will be easier. There's no point using a Caucasian MOEM, which is more of European in nature, European or American in nature, or Asian MOEM, which will be Korean or Japanese. So what are the things which we can identify? We can identify Down syndrome, we can identify trisomy 18, we can identify trisomy 13, and we can identify OSP and SLOS. And we have these markers, we already have the APA and OPP and thyroid. And in case of second trimester, we have serum AFP, total beta HCG, diabetes AFP, and we can also test amniotic fluid AFP as well. We currently do not have a trophoblastic antigen as well. I mean, not only us, none of the companies have this increased trophoblastic antigen. And some of the laboratories have developed their own unsafe methodologies. Other than that, in India, no one has IP. So, what are the reports which can come out? We can do the people's portable and data screening. We can do the amniotic fluid. We can do the independent screening, attendance, training, sequences. The advantage which we have in case of, we also have all the different certifications required because, as I mentioned, the Benedict software is approved by ACOG, the American College of Obstetrics and Gynecology, and it is also used by many of the CLAP certified laboratories, the College of American Technology certified laboratories. So, the different software versions, I mean, based on that, we can also deconstruct the results. We have 9 versions of the report format. So depending on what is required for your physician, we can have that particular report format being showcased. And it basically gives you the advantage of showcasing with regard to whether the risk is there or not in case of trisomy 20, trisomy 13, and PE. So this is the report format 3, where you can see the integrated report for both the second and first trimester. So even if you are being a tier 2, tier 3 area here, many times what happens is they may do the NP, but they may not do the first trimester because they may be away of they may be beyond 23. So that way, this software comes of help because then we can even do the screening between the 12 to 14 weeks. And I will just show you what are the factors influencing the date of birth of the mother, then the gestational age, number of pregnancies, mother's race, then the diabetes status, the weight, the RH status, family history information as well. So all this is captured in the report as well. I'll just show you the report before I file that. So this is how the report looks. I mean, if you look at it, in the patient's age, I mean, apart from the name and other things, the weight, the pregnancy details, whether they, I mean, if you're having all the data, including the MMT or the scan report, then the diabetes status, then the ultrasound on the details, then whether it's a twin pregnancy or not, the previous Down syndrome history, if there was a previous Down syndrome history, that can also be recorded. All this will help with regard to the final result output, and it will help in identifying whether the patient is going towards Down syndrome or not. So this is what I wanted to present in the limited time, that I hope it was a good session, and I thank you for giving me this opportunity as well in this regard. In case of any queries, please feel free to let me know, and I can always, if I don't know, I will come back to you. Thank you.
Thank you, sir. Very nice interactive session. Very thoroughly, you have presented about the diagnostics, admissions, about the message which are available from vocabulary disasters. Also, you have very nicely covered the Down syndrome, how the letters is and how to calculate the risk. You have told us about the process, map, as a characteristic, and the software that Benedict software for Down syndrome. Very nice. One question from my side. You already said that 81% of women they are not unstable.
Yeah, I mean, because that's the current available data.
So, in a source limited setting like India, is it possible to screen all the women?
So it is not possible. But as I was telling you, in 2005, 2006, when we started, then when I started my journey in Down syndrome, that time it was only 2%. So from 2%, I was telling you only 1 lakh people were getting tested for first trimester, and 4 lakh people were getting tested for second trimester. From that, we have now improved to 15 lakh first trimester and 25 lakh second trimester. And our birth rate has come down from 28 lakhs to 28 million to 27 million. But the thing is, our maternal age is also now increasing because people are more career oriented, their marriages are getting delayed, and also as we have many issues. I mean, if I can only talk about lifestyle diseases, I can go for an entire day. I mean, even earlier, if we look at it, all of us, the earlier generation, we were made to take oil bath every Sunday. Our parents used to apply oil all over the body, made us to sit in the veranda so that we get the early morning sunlight. And so it will open the pores of the body. Whereas today's generation, they start the day with the pizza, in the afternoon they have a pasta with Pepsi, and in the evening they have honey. Classic case of celiac disease. And we become more diabetic. Earlier celiac disease was seen only in pin code 1, only in North Africa, whereas today it's seen everywhere. Similarly, this is also increasing. Awareness is increasing, so that way it is good. But we are nowhere healthy from that perspective. Only when it goes from India to US or Europe and comes back, our eyes open. Otherwise, then what is available here, we do not open.
Thank you, sir. Thank you very much. Any questions from the audience?
Thanks a lot, man. Thank you.
Thank you, Dr. Suresh Chandrasekhar, sir, for imparting precious knowledge with us. Thank you, Dr. Manju Chandrasekhar and Dr. Nandakishore Bankar, sir, for chairing this session.
I would like to invite Dr. Nandakishore Bankar, sir, and Dr. Manju Chandrasekhar, madam. We visited our speaker, Dr. Suresh Chandrasekhar, sir. I request Dr. Reena ma'am to felicitate our chairperson, Dr. Manju Chandan Khade ma'am, Dr. Kishore Bajwar sir. Thank you, ma'am. Thank you, sir. For the fourth session, which will be focusing on clinical applications of flow cytometry by Dr. Komal Galani ma'am, I would like to invite Dr. Prakash Moite sir and Dr. Neha Bhatt ma'am to chair the session. Dr. Moite sir will be joining us soon. Dr. Prakash Moite sir is a professor and head of the Department of Forensic Medicine at Datta Mehta Medical College, Nagpur. Sir has a vast teaching experience of 20 years and has 34 publications in scientific journals and 3 publications of chapters in textbooks.
Associate Professor, Department of Pathology at the College. She has a vast experience of 10 years in government practice.
Very good afternoon all. So our next speaker is Dr. Komal Galani Deshmukh. She has done her MD from Tata Memorial Hospital in Mumbai, and after her discharge from the same hospital, she shifted to US for her fellowship in laboratory medicine, which she did from Mayo Clinics. And she also worked in the Regional Cancer Center, RSP Regional Cancer Center here, and also CMC Bangalore, she trained for transfusion medicine. And she has been an ex-consultant in SRA, and right now she is director of Phoenix Pathology Lab, which specializes in 24/7 lab, and it specializes in flow cytometry, and it's a reference lab. What do you call?
Thank you, Dr. Neha, for the warm introduction. At the outset, I would like to thank Datta Mehta Medical College Hospital Research Center for giving me this opportunity. Quickly, I will be dealing with clinical applications of flow cytometry. Next slide, please. To understand what are the applications of flow cytometry, I would just be giving you a brief insight on what is flow cytometry. It's very important to understand the concept behind it so that we can know what are its applications. Now, flow is nothing but measurement of cellular properties as the cells move in a single stream, in a fluid stream, a single set of in a single stream past a stationary set of detectors. So there are 3 important components of any flow cytometer, which includes fluidics, optics, and electronics. I know it may sound a lot of physics into it, but until and unless we do not understand its basics, we will not understand its uses. Next slide, please. Now, as we told, fluidics play an important role in the flow cytometer. It is because of the sheet fluid wherein the cells are forced to pass through in a single file manner. This fluid is called as the hydrodynamic focusing, which is the principle used in any flow cytometer. So hydrodynamic focusing means with the help of fluid, the cells are made to pass in a single line of inspection in a linear manner. Now these are some various flow cytometers available in the market, but principle remains the same, that of hydrodynamic focusing. These are basically the optics. Now here there is a laser light source. Depending on the number of lasers used to it, the laser light passes through single beam of the cellular suspension, and when the cells are tagged with various fluorochrome tag antibodies, they emit different rays, different lights. These lights are collected by these photomultiplier tubes, and what data we receive with the help of software, it is converted into electrical to digital signals, and what we see are various dot plots and histograms. Again, these are different types of filters, some which allow light of particular wavelength to pass through, and the others to different pattern. This is how basically a flow cytometer machine looks from inside. Here you can see there are three different laser channels. What we mean by fluorescence? Fluorescence is basically absorption of light of a lesser wavelength and emission of light of a longer wavelength. Why are we worried about all these fluorochromes and antibodies? Why? Because the antigens on any of the cells are tagged with these monochrome antibodies. They absorb light in a particular wavelength and emit light of a longer wavelength. So these are some of the commonly used fluorochromes, which include CPE, there is a condition called as fluorescence emission spectrum. One fluorochrome, it gives signals into the signal spills over to the other fluorochrome. If we are aware of this entity, we will be able to correctly interpret our histograms correctly, able to interpret our spot plots. That's why we should know what are these entities. The fluorochromes, they do not emit at one wavelength, but they emit in different spectrum. The procedure of compensation basically is an electronic method that subtracts the percentage of fluorescent signals spillover into the other, okay, to avoid the spectral overlap. I will not go much into the detail. Next is how we analyze these electronic signals I told you are converted into digital signals, and what we see are the dot plots or the histograms, which are easy to interpret. Again, the excitation spectra of different fluorochromes. This is what the final report or the final outcome looks like after processing a sample for flow. When we run the sample, this is what a normal histogram or plot looks like. On the x-axis, we have forward scatter, which represents basically the size of the cell. I just take 2 minutes on this because it is very important to understand what is the normal dot plot looks like, so that we can interpret the abnormal. Now, as I said, on the x-axis is the forward scatter, which represents the size of the cell. On y-axis is the side scatter, which detects the internal complexity or the granularity of a cell. Now, as you can see, the lowermost are the lymphocytes, which have small size, and absolutely no cytoplasmic granules. Sometimes you have large granular lymphocytes, which are very less than 5% of the total blood cells. Hardly maybe able to get it in this location. Next comes are the monocytes. Though the monocytes are the largest cells, but they still have very few fine cytoplasmic granules. That's why the side scatter is higher than lymphocyte, but definitely less than those of the neutrophils. Now, this is the region where most of our neutrophils image of granulocytes die. Why? Because the size is large on the x-axis, but on the side scatter, they have lot of internal complexity being shown, lot of full of granules. Now, again, why is this important? It's like in the anatomy, someone teaches us the next time you're going to do a surgery, this is why the anatomy is important. Same thing in this. If I'm going to tell you the cells of acute thrombocytic leukemia are going to lie here in this neutrophilic region, right? So it is very important to know which cell would lie where, so that you could compare. The normal lymphocyte would lie here, lymphoblasts would lie here, CLL lymphocytes would lie here. So how are we able to differentiate between that? Now just seeing a basic plot without any antibodies would tell us what is the most cellular population in the sample. Now in this sample, as we can see, most of the dots are here. So this is a peripheral blood sample with most of neutrophils. There are few lymphocytes as well as monocytes. This is absolutely a normal picture looks like. We should be aware that flow is a very sensitive machine. It will pick up even the dust particles it will sense as a cell. But where do the light become light is debris region. If you are aware of this, if you know this, you will prevent mistakes. Prevent mistakes in interpreting. Now when you get a leukemia sample where there is 80-90% glass, almost a homogeneous population, not difficult to interpret. But what if the patient is coming on follow-up after treatment and you have 5, 6, 7, 8% glass? There comes the role of your flow and various different antibody compositions and study. Common applications is flow cytometer is used to detect abnormalities in all 3 lab cells, RBCs, WBCs, and filtrants as well. Though the most of the role of flow cytometer is in oncology setup, but the other non-oncology, non-neoplastic workup is also a huge task. Most commonly tests which in hematology are HLV-20 cell detection. In seropositive patients, we look for CD4 counts, CD48 counts. There are also patients on rituximab, especially those under hematological diseases or those with dermatological conditions who are on follow-up and being treated with anti-rituximab, which is anti-CD20. Here, 19 and 20 counts are done to know what are the number of T cells. Sometimes to prognosticate whether the patient will be having a flare up of SLE, wherein the patient is on rituximab. We monitor this patient with 19-20 counts. Similarly, for other histocompatibility cross-matching and transplant rejection also there is a role of flow cytometers. As I told you, most of the application here is in oncology, wherein we do immunophenotyping of all types of leukemias, lymphomas, myeloma workup, myelodysplastic syndromes. Now, not only diagnosis, but also in prognosis and disease follow-up in monitoring the minimally respiratory diseases done by a flow cytometer. Studies have shown that overall survival rate is significantly impacted in presence of this minimal respiratory disease detected by flow cytometer. The most important application, again, I would say in oncology setup is bone marrow transplantation. That is CD34, the stem cell count. CD34 stem cell count is being done on a flow cytometer using ISAGE International Protocol. Again, CD34 bone marrow transplants are not only done in oncology settings, but also in benign conditions, including thalassemia, sickle cell. We have been trying very hardly to persuading the government to establish a central bone marrow transplant unit for Vidarbha, which is the capital of the city. Again, different DNA quality studies could be done using a flow cytometer. The other routine hematology applications include the reticulocyte enumeration, studies for paroxysmal nocturnal hematuria, various autoimmune, alloimmune disorders, anti-platelet antibodies. Other than CD41, 61, including IgG, IgMs, anti-neutrophil antibodies, there is a vast work on immunodeficiencies, both in cases of children as well as adults, using a flow cytometer. Again, this is briefly just a repetition of what I have said. Depending on the cellular properties, the components which are analyzed. Again, the basic question, what is the sample required? When we say we want to run the cells in a single file, what is the sample required? The sample would be the peripheral blood, which has diagnostic cells. So either 2 ml PDT, actually we need a flowing sample. So we need sample and PDT. Okay. Then bone marrow samples, 1 ml is sufficient because generally marrows are very cellular compared to peripheral blood. Flow cytometry could also be done on body fluids. Yes, those body fluids are very suspicious. Sometimes the disease is limited only to the fluid cavities. It is not seen in the peripheral blood. Marrow is not yet involved, so we are left with body fluids. But do not worry, body fluids are subjected to flow cytometry. I have a good couple of cases I will be sharing soon. Pleural CSF, including pericardial fluids, can be subjected to flow cytometry. Important is we need vital cells. We need vital cells. Just in case of fluid, there is no preservative. We need to process the fluids fresh. So generally within 2 hours of collection. Turnaround time of the test is very less. Flow samples have to be analyzed quickly. Again, I tell you, most important is sample preparation. There have to be no clumps, no debris, single cell suspension. The hydrodynamic focusing is the principle of flow cytometry. The beauty of the machine is cells here run in a single file. So when the cell which is tagged with various fluorochromes, the antigens are present on the cell, the antibodies will emit a certain wavelength of light, and that's how we are able to capture the signals. Okay, as I told you, the machine is very sensitive. Dust particles are counted as events, so we need to have a dust being removed. But all said and done, very important. First and foremost is the morphology of what we are going to do. If we do not have a morphological impression, we cannot proceed doing a procedure. You have hundreds of antibodies, you cannot just apply hundreds of antibodies and come up. You have to have a working differential 1, 2, 3, and accordingly you put up a panel and decide what is it. Flow cytometry is nothing but a liquid IHC ice. The solid IHC takes time, but liquid IHC is you get the reports within 3 hours, and it helps the patient monitoring and treatment. The main goal is in immunophenotyping of hydrolymphoid malignancies. The primary goal here is also to confirm the blast, as I told you, in cases of where there is dysplasia, where the number of blast count is less. Flow definitely helps us give a confirmation of the presence of these blasts. Then sub-classification in certain cases, lineage assignment of these blasts. Also, there are some prognostic markers which could be detected by the flow cytometry process, and the most importantly, minimal associated disease in cases of follow-up patients. In cases of lymphomas, what do we first assess on pathology? Are these lymphocytes clonal or reactive? If they are clonal, what index do they belong to? T cell or NK cell? Most of the B cell malignancies are BCLL, that's chronic lymphocytic leukemia. If they are not CLL, what cells are, what type of lymphoma it is? Again, in the case of T cell, it's a huge classification for T cell, where there is a gamma delta T cell lymphoma, which looks more like blastic morphology, but markers are those of a lymphoma. Again, NK cell, it is difficult to deal with NK cell markers. This is one of the charts which shows normal B cell maturation. One of our mentors, Dr. Wood and Dr. Horowitz, he has shared this nice article wherein he has mentioned the maturation patterns of each lineage. B cell, T cells, myeloid cells, granulocytes, monocytes, everything. Herein, the presence and absence of the marker is shown by the colors, and the intensity refers to the intensity of the antigens which are expressed on the surface. I'm going to share some interesting cases. Case number 1, this was a 45-year-old male who presented with leukocytosis. Now, it was very evident that this the patient has anemia, thrombocytopenia, and there is blast with moderate amount of cytoplasm from nucleoli, chromatic. These blasts were NPO positive. Our role ends here when we give the diagnosis. But flow helps us in further typing this, further advising requests for further studies and ancillary techniques. As you can see, this is a normal plot I said. Again, concentrated red cells are the population of interest. Colors are all mandated. We can color any color which we want, but generally red because it indicates alert attention. Red population is where the blasts are. These blasts are lying in the monocytic region, as we can see. Monocytic region. They express moderate CD45. Lymphocytes are the strongest CD45 antigen expressing cells. These cells are positive for CD34 and anti-NPO. So we said this was AML, yes, slightly AML, case of AML. But what about the other markers? The other myeloma marker CD33 almost negative. Actually, DR is positive. 13, 15 is positive. What was interesting in this case was CD19, which is a B cell marker, is positive in this case. CD19 is positive. So what are we doing? Is it a biochemical? No, it is not. Why? Because cytoplasmic markers are the lineage dependent markers. Cytoplasmic MPO is positive, that means it is AML. Cytoplasmic CD20, 79, alpha 22 are absent, that means it is not a biochemical, it is not a myelinic leukemia, we are still dealing with AML. The other marker which is positive is this CD117, CD15, and another was CD56. So CD56 being a marker of T NK cells, plasmacytic dendritic cell. What are these markers doing here? These are aberrant markers. If we know what are the normal maturation patterns, we will pick up these abnormal markers. Okay. So we give a diagnosis of AML M2 with CD9 aberrant CD19 and CD56 expression. Now there is an entity which is called as AML A21 expression. It is very typically expressing CD19 and CD56. Again, if this was A3 advised A21, A21 give positive in this patient, which is it carries a good prognostic marker, but CD56 is a bad prognostic. Okay. Next case, this was the 15 years old female with a mediastinal mass and deep fluid. Most of it was hemorrhagic, as we could see. Most of the population is a small blast-like looking cells. Again, it is very well depicted in the dot plot. Most of the cells are coming in line in the lymphocyte region. There are no other cells. These cells are expressing CD45 very strongly. Again, CD7 is strongly positive. Here you can see CD4 is gold negative. CD56 is positive. Cytoplasmic CD3 is positive. Though CD3 is negative. CD10, CD19, other markers are negative. CD7 is the earliest marker of T cell infection. And cytoplasmic CD3 is specific for T cell infection. The other markers are shown here. So this was basically a case of T acute lymphoblastic lymphoma involving the fluid. Case number 3, 75-year-old female presented with cough and resistance since 20 days, recent onset. Patient had weakness, loss of appetite. TBC, other than anemia, platelets and PSA was normal. Other investigations were normal on X-ray chest, which showed a left-sided fluid effusion, which was stabbed. As we could see, the severely dispersed abnormal cells, morphology, giving us a morphological impression of Burkitt's lymphoma with a lot of accumulation, both cytoplasmic as well as nuclear, very characteristic. But beware, patients, those who have been given steroids, they also can show a similar picture. So again, it lands up to what are we dealing with? The patient is subjected to flow cytometry. As you can see, here the cell size is large. Those are not like lymphocytes. Normal lymphocytes are these. These are the empowered population. Site scatter is very high. Forward scatter is very high. They are expressing strong CD45. Strong CD45. Definitely, we are dealing with the lymphoma leukemia. CD5 was negative. Cells were expressing CD20, CD10 very bright, more than the normal. Normal levels and here CD was 10:4, but these are way beyond 10:5 here. That is why if we know normal, we know we pick up abnormal. We have positive CD20, CD10, CD38, HLA, DR, these are B cell lineage markers. CD79 alpha, CD22. Now, if we say kappa and lambda, only population of C, both the markers are negative, kappa as well as lambda. Having a total population becomes easier to pick up. But when both are negative, it is all the more easy. Again, that is advantage. While mature cells, which are strongly positive for all the B markers, not having any of the kappa or lambda, that means either they are dealing with a lymphoblastic case, lymphoblastic lymphoma, or lympho B-cell leukemia, which is affecting. We reported these cases will be called as high-grade B-cell lymphoma. Most common DD was topmost on the DD was Burkitt lymphoma because of the morphology. Again, DLBL, germinal center type, CD10 was strongly positive. Entity like B-cell lymphoma and classifiable with features intermediate between DLBL and Burkitt. The thing is, flow does have a limitation, but yes, it can give a way guideline to the it can give a start for the patient to start the treatment. It can help the clinician to immediately install the treatment. Patient must have high-grade excellence. So these we need further IHCs and molecular markers to establish. So next case. The 55-year-old male, again presenting with lymphocytosis in the peripheral blood. As you can see, most of the lymphocytes are showing some tight cleaving. As we can see, a few neutrophils, most of the population is in sites of lymphocytes. These cells are strongly CD19 positive, and this is what I say we have nice donor population. Kappa is negative, lambda is positive. We say, what about these populations which are kappa and lambda dual positive? Beware. Once you practice, you will know. Kappa, lambda, both the light chains are give very non-specific signals also. These antibodies are very sticky. If you do not process the sample well, if you do not remove the serum properly out of the cell population, these antibodies get sticky. See where you are lying in the region of death, right? That means they are useless signals. So you're not supposed to see this signal. This is kappa and lambda, lambda clonal population. So we were dealing with a 20 lambda population, 19-20 positive. We were shortly dealing with a B-cell lymphoma. What type was it? CD10 is positive. For the classified, CD10 is positive. CD200, which is a marker specific for CLL, that is absent. So we knew we are not dealing with CLL, but with a B-cell NHL, which is CD10 positive, shows cleaning of the cell. CD5 negative. And we reported this as a follicular lymphoma with peripheral blood lower. Other applications of CD flow cytometry, as I told you, HLA-B27. We just do a qualitative study whether the HLA-B27 is positive or negative. Study it on the lymphocytes with the markers. As you can see, this is negative for HLA-B27, whereas this population is positive. This patient is positive for HLA-B27. Again, the CD4 count, which helps us in case of seropositive patients to decide which treatment has to be given to the patient, or what follow-up the patient has to be, which preventive medications the patient should be on. And depending on the count, the patient is likely to suffer from certain particular parasitic or viral diseases. So prophylaxis for the same is mandatory. Hence, proper counting estimates of these CD4 counts is necessary. Just to summarize, flow cytometry is a very powerful technique for portraying multiple characteristics of a single cell. Most commonly used applications are HLA-B27, CD4 counts, immunophenotyping of hematological disorders, monitoring of these patients, and other structural properties assessment for lymphocytes, leukocytes, and thank you everyone for the patient hearing. This is my team in which I work. Any questions? Cytoplasmic vacuoles Why? Because in case of different depending on what test we are analyzing. So for leukemia lymphomas, the general pattern is 10,500 markers. Lymphomas equal to 40 markers. Markers are very expensive, antibodies are expensive, but utilizing we have the report in 3 months. And for some, when you try and compare the cost of diagnosis and the cost of treatment, cost of diagnosis has to be less. So when we are going to install a treatment both bags, thousands are various now. Yeah, we have been doing so now since last 6 years in the city. I've done around hundreds of samples of bone marrow transplant in 2024. And definitely around 500 cases of leukemia lymphomas typing. HLA and CD4 becomes a very big type CDC. So I'm having
Thank you so much, ma'am, for your nice and informative talk on application of flow cytometry with various clinical scenarios. Thank you very much.
Study to understand it, but it has been made very simplified and made us understand it to quite a lot of extent. Thanks a lot for that.
Thank you, Dr. Komal Balani ma'am, for the management session. Thank you, Dr. Prakash Mehta sir and Dr. Neha Bhatt ma'am for chairing the session.
I would like to invite Dr. Neha Bhatt ma'am and Dr. Prakash Mehta sir to felicitate our speaker, Dr. Komal Balani ma'am, with momentous now and distinction. Now I would like to I request Dr. Anita Sajjanar ma'am to felicitate our chairperson, Dr. Prakash Mehta sir and Dr. Neha Bhatt ma'am.
Thank you, sir and ma'am. After this decade exhaustive list of knowledge, let us speed up the epic every summer and brain traces and proceed for the delicious lunch. Half an hour, continue with the sessions.
Yes.